Hi, Miss Masuma.
Hi, how are you?
I'm fine. How are you doing?
Good evening, dear. How are you?
Good evening. All well?
Yes, thanks for that.
Trying to get all the speakers to join in. At exactly 1 minute before 6 o'clock, we will start to introduce Miss Afra Binkata, which is the first speaker for today, correct?
Yes.
Okay. I'll try to get them on board, but if in case, we will start at exactly 1 minute before 6 o'clock.
Okay.
Okay. Before we start, I just want to make a small announcement, attendees, that unfortunately, there was supposedly a sponsored session from Abbott, but the speaker couldn't make it. So hence, we are moving and following the program itself with our next session.
Okay. You will announce.
Yeah, it's been informed to them.
Oh, okay. Good evening, Dr. Nader. You mute. Make unmute, please, Dr. Nader.
I did. دكتورة معصومة ازاي اخبار حضرتك؟
الحمد لله دكتور، كيف الحال؟ شخبار؟
الحقيقة الحمد لله كل اموري بخير. I was following the sessions with the discussions وكمية ال knowledge that was gained, that's something مش عايز اقول لك amazing. يعني how people really they should learn these things, they should have awareness on what to eat, how to live. مش عايز اقول لك يعني it's too much knowledge. something amazing يعني، فالله يوفقكم يا رب، واتمنى ان ده ينتقل الى البابليك so people they become more aware عن الدايتري هابتس.
دكتور نادر، التوبيك اللي بتتكلم عنه اللي هو patient
centricity exactly.
هو تركيز على المريض، على العميل.
يس الفكره ايه يا دكتوره معصومه؟ انا حضرتك I started my career as a medical doctor. اشتغلت 8 سنين وامسجت سبيشالست وطلعت التاسع على دفعتي، بس الحقيقه الكارير was not the best for me. فسبت المهنه واشتغلت مع جانسن، اشتغلت ميديكال ريب وبعدين سيل سوبرفايزر، وبعدين انتقلت السعوديه اشتغلت هوسبيتال سيلز مانجر ماسك كل التيم اللي بيزور الانستتيوشن. then I moved للماركتينج، وفي 97 I moved للتريننج. ابتديت في التريننج اتعمق في حاجات زي الكوميونيكيشن والسوشيال ستايلز وهاو بيبل كوميونيكيت، وابتديت اطبق السايكولوجي اللي انا عارفه. فطبعا وبعمل دورات كتيره جدا فور ذا هيلث كير بروفيشنالز، يعني ده ورك شوب انا بعمله برضو للهيلث كير بروفيشنالز. احنا عندنا a lot of challenges، ما عندناش وقت للمريض.
ايوه صح.
حضرتك في عيادتك بتشوفي كم عيان في اليوم؟
صح كلامك.
فيو دونت هاف ذا تايم فور ذا بيشنت. العيان بيحس بده، العيان بيحس ان هو ما عندوش وقت يقول كل اللي عنده، وده اللي انا استفدته من البراكتس بتاعي. يعني انا العياده بتاعتي الحمد لله كانت ناجحه جدا. I wasn't the best in knowledge، بس كنت بدي وقت للعيان على حساب وقتي الخاص. فكنت ابتدي الكلينيك بتاعي الساعه 3 الظهر، اخلص الساعه 2 بالليل او الساعه 3 بالليل just because I'm giving time to the patient. فابتديت اكون فكره عن what the patient want، ايه اللي البيشنت محتاجه beyond the scope of diagnosis او treatment. فام just sharing my thoughts وام opening
very
many
good. I like it by the way, Dr. Nader, your topic. صراحة it is interesting.
it is لان بيخلينا نبص شويه من ناحيه البيشنت اكتر ما احنا دايما بنبص من ناحيه الطبيب او من ناحيه الديزيز. فيا رب يعجبك دكتوره يا معصومه ان شاء الله.
انا والله العنوان it was very interesting، لان انا اتعامل مع المرضى دكتور نادر واعرف هالمواضيع، ان مش فقط نعطي information for the patient, we have to know it other things behind what is
exactly
happening, how they will implement، كيف هم يكون تطبيق هالمعلومات اللي انت خبرتهم.
صحيح.
مع يعني really it is interesting.
تحت امرك دكتوره معصومه.
تسلم
والله
دكتور، ما تقصر، والله ما تقصر.
بليجر. وفي اي وقت if you feel ان انت عايزه تعملي الورك شوب ده at your place
يا
I will
ريت ان
be
شاء الله.
honored I will be honored to come to your
ان شاء
place
الله
and
يمكن في نوفمبر دكتور
تحت امرك.
ان شاء الله بيكون في نوفمبر عندنا السيمبوزيوم، فان شاء الله نشارك معانا.
my honor. لان الحقيقه يعني مش عايز اقول لحضرتك انا من وانا في الطفل في ال6 سنين وانا كان نفسي اطلع دكتور، ولدرجه ان انا وانا في الهاي سكول كنت بروح فور تشاريتي بولي كلينيك جنب البيت عشان اغير للعيانين واساعد النيرسنج ستاف، لان الهيد نيرس شي واز ماي اونتي يعني. فابتدت تعلمني
Sorry to interrupt, Miss Masuma, Dr. Nader.
Please do.
Shall we start, please?
Of course. دكتورة حبيبة مساء الخيرات.
دكتورة حبيبة مساء الخير.
السلام عليكم.
السلام ورحمة الله وبركاته.
How are you معصومة؟ How are you دكتور؟
الحمد لله. All is good. Always good. الحمد لله.
الحمد لله. We can start?
Yes, please. Let's start, Miss Masuma.
Afra there with us?
Yeah, it's okay. It's okay. She will be.
Salam alaikum. Good evening, everybody. This is Mahsouma Al-Jasmi, head of the nutrition section in Al Jalila Children's Hospital. I will be moderating the incoming 4 sessions for today, and we will start with the first speaker, Miss Afra bin Kitta. Miss Afra bin Kitta, she's a specialist clinical dietitian and head of the clinical nutrition department with 18 years of experience at Rashid Hospital and Dubai Hospital, as well as she is also the president of the Emirates Clinical Nutrition Society, as well as the board member in Emirates Medical Association till date. Her extensive experience in intensive nutrition care of the adult with the critical care. She graduated from the United Arab Emirates and hold a master from the Alexandria University, Egypt in nutrition and public health. Afra has also contributed with, with the DHA program accreditation and the re-accreditation student training, supervision and organizing of the nutritional related health promotion activities for the hospitalized patient community. Along to that, she took part excellent project in that on Hamdan bin Mohammed Award. Please help me welcome Ms. Afra bin Kitta as she speak as on overview of the nutrition management of bariatric surgery. Welcome to Ms. Afra. Ms. Afra.
Good evening, and it's a pleasure to welcome all attendees. I want to send special thanks for Professor Aisha Dhahri and her team to invite me for the successful conference. Today I'm going to talk about the nutrition management in bariatric surgery. So let us to begin with WHO published regarding the prevalence obesity in the world, as well as research study done in UAE. In 2016, more than 1.9 million, around 39% of adults, include 39 of the men and 40 of the women, were overweight. Over 150 million, around 30% of the world adult population, 11% of men and 50% of the women were obesity in 2016. As mentioned also, overweight and obesity are linked to more death worldwide than underweight. As well, the WHO emphasized the fundamental causes of the obesity and overweight is in energy imbalance between the calories consumed and calories expended. Furthermore, the 2030 Agenda for Sustainable Development recognized non-chemical diseases as a major challenge for sustainable development as part of agenda. Government committed to develop ambitious national responses by 2030 to reduce by 1/3 premature mortality from non-communicable diseases as obesity. through prevention and select appropriate treatment. In 2017, prevalence of obesity and associated with non-chemical diseases are extremely high in UAE. Expatriates were overweight, 43% overweight, and obesity had 32.3%. So we have to know the healthy key, came from the weight management. So what is the weight management? It is the term used to describe both the technique and underlying physiological process that contributed to the person's ability to attain and maintain certain weight. Most weight management techniques encompass long-term lifestyle strategy that promote healthy eating and daily physical activity. Moreover, weight management involves development, meaning full weight to track weight over time and identify ideal body weight for different individuals. And select the appropriate obesity treatment strategy depend on the goals, health risk of the patient, and merge, combine, integrate between different interventions. Integrated nutrition intervention options include the following, like a low-calorie diet, macronutrient adjust eating plan, increase physical activity, lifestyle modification, more frequently self-monitoring, alternative medicine, mindset, and also we can add the pharmacotherapy and surgery like bariatric surgery. So we can change it between them as the intervention, comprehensive intervention. And today, I'm going to talk about the bariatric surgery as mentioned previously, and my talk will be on significant results came from bariatric interventions. The American Society of the Clinical Endocrine and Obesity Society and the American Society for the Metabolic and Bariatric Surgery evaluated pre- and post-surgical management strategy for obesity treatment and outlined consequence and evidence-based practice guideline for bariatric centers and institutions that specifically provide bariatric surgery procedure and long-term obesity management. And they mention the bariatric surgery is currently the most effective treatment modality for morbid obesity when compared with non-surgical interventions. The main benefits of the procedures include prolonged weight loss and improved obesity-associated comorbidities and quality of the life. Facts and studies in the bariatric surgery. The studies shown the blood pressure levels have been shown to return the normal after surgery in 65% of the obesity patient with type 2 diabetes. Lower serum cholesterol levels, more than 90% patient will develop normal cholesterol level within 6 months after the operation. Low blood pressure, at least 70% of the patients who have high blood pressure and who are taking medication to control it are able to stop medication and have a normal blood pressure within 2 to 3 months after surgery, as well as shown the health improvement in heart diseases, sleep apnea syndrome, low back pain, degenerative disc, and joint diseases. Eligible target for bariatric surgery. In 1991, the NIH set eligibility criteria for bariatric surgery, which include body mass index equal or more 40 without coexisting medical problems, or equal body mass طبعا index equal or more than 35 with one or more severe obesity-related comorbidities. We agree that severe obesity is a chronic condition that is very difficult to treat. So the surgery procedure to promote weight loss by restricting food intake or interrupt digestive process is in options for severely obesity people. So again, the way that surgical procedure promote weight loss are whether by decreasing food intake, which called restriction, or by causing food to be poorly digested and absorbed, which called malabsorption. Nutritional management protocol in bariatric surgery, and this is important part for us. As we know, the nutrition intervention include progression of meal planning should be customized individual, as we have kinds of consideration should be care of it to obtain the successful results as follows, like establish goals, technique for drink and eating, nutrition supplements. Also, we are considered the easy preparation of the supplement, easy observation, acceptable test, as well planning for the diet meal plans, whether pre or post surgery, as well follow up, and our expectation from all this is intervention. Pre and post nutrition education goals. So we will start with the goals. The first one is improve the nutrition status, whether pre or post surgical, as correct vitamin and nutrient deficiencies. Most common include in this procedure iron deficiencies, vitamin B12 deficiencies, and vitamin D. Promote 5 to 10 weight loss to reduce surgical risk. This is for a pre-surgical period, because the study shown that the weight loss was associated with the marked reduction in improvement post-operative complications such as anatostomic leakage, deep infection or abscess, and minor wound complication. Achieve of the better control to nutrition-related comorbidities and complication, like dumping syndrome, relaxin, early satiety. This is all for post-surgical. Promote intake of sufficient energy and nutrient to also healing and prevention of the lean tissue during the period of rapid weight loss. This is for post-surgical. Development of the lifestyle and eating habit that will promote positive post-weight loss surgery outcomes and weight loss maintenance status. Nutrition intervention of pre-operatively. As per studies, when the several pre-operative diets were compared within the duration of the diet range from 2 to 6 weeks, as per recommended on low carbohydrate diet, was found the more effective than low fat with regarding to short-term weight loss, as improvement in insulin sensitivity and reduction in lipid concentration. The former diet showed the positive effect, especially in the patient with the metabolic syndrome or non-alcoholic fatty liver. As mentioned, also a very low calories diet as a sole method for multiple weeks may induce a catabolic state, which could potentially harm recovery after surgery. So within 24 hours of pre-surgery, day before surgery, we have to put the patient on the full liquid diet. Liquid diet after midnight, we will start it. 2 hours prior of surgery to stop drink of all liquid. The nutrition intervention of post-operatively focus on high protein foods can help healing the wound and avoid muscle wasting. Avoid food that are high in fat and sugar, because it is cause the complication and symptoms. There is symptoms for that. and limited consumption of the calories-dense food and drink. Nutrition recommendation and nutrition recommendation of the post-operatively. Energy requirement 20 to 25 calories per day. This is for adjust body weight because we are handling this with the obesity patient. Protein at least 25% from the total energy. Fat should be 25 to 30. Why? To maintain gallbladder empty and reduce the risk of gallstone formation. Carbohydrate 50 and fiber should be gradually introduced based on the patient progress toward the consumption of a solid diet. Fluid adequate consumption to reach more than 1.5 liter. It should be gradually and to avoid dehydration. Generally, multivitamins and mineral supplement is needed. Volume and consistency of foods provided depend on the post-operative stage and individual tolerance. Technique of taking the food and the drink. Eat frequently small meals, 4 to 6 meals per day. Cutting food small, chewing very well. Wait 15 minutes before a meal and 30 minutes after meal to drink liquid. Stop eating when you feel full. Recline after eating to avoid lightheadedness. Don't try new foods one at a time. Avoid very hot or cold food. As we know, dietary recommendations are based on gradually progression in the food consistency and texture over 1 to 2 months. The patients are instructed to being with clear liquid at room temperature for 24 to 48 hours post-surgery. As I said, increasing the volume gradually. Drink liquid a small portion as tolerated with no more than a half cup per serving. So we started with a stage 1, it is up to 3, it's on clear. Stage 2, full liquid up to 40 days. Stage 3, soft or mash diet, it is up to 35 days, and after 6 weeks, we can start regular diet. Follow up and expectation, very important part also. Monitoring. We start with the monitoring. Periodic medical evaluation are recommended following bariatric surgery. After bariatric surgery, first 6 weeks, it should be every 4 to 6 weeks evaluation. Second 6 weeks after surgery, the frequency of evaluation, it should be every 3 months. We have to evaluate the patient. After 1 year annually, or if the patient have a clinical indicator or clinical sign, we have to follow up on time. An expectation of weight loss from the procedure. The common procedure, it is like gastric bypass. The expectation of weight loss, 55 to 65% of the weight loss must be lost from first year. First year we can see, and also sleeve gastrectomy, 40 to 55% of excessive weight must weight loss seen in 1 to 2 years after surgery. And we have a critical procedure as duodenum switch. The expectation of the weight loss, 60 to 80% of excessive weight. Most weight loss seen in the first year. So it is critical procedure. So we have to be care of the patient.
Miss Afra, we have 3 minutes.
Related the complication and risk, like dumping syndrome. It's always happened with our patient, so we have to be careful. The symptom is diarrhea, nausea, dizziness, weakness, and so on. And prevention by avoid high simple sugar and because it is high glycemic index, as well high fat food, chewing as technique, chewing the food well, eating slowly. A portion, we have to control the portion size to become small, avoid liquid with the meals. As well, combine the complex carbohydrate, protein, and fiber in the meals. Nausea and vomiting, diarrhea and constipation, dehydration, gallstone, the back open of your stomach pouch, develop nutrition deficiencies, it's happen, as well the starvation response. Because following very low calories diet causing a severe reduction in your daily energy expenditure by lowering your metabolism, increase hungry and leading to breakdown of the muscle for energy.
Miss
As
Afra,
well, the weight gain or failure to lose weight. There is some of the causes of surgery failure as hormonal factors, hormonal in thyroid, parathyroid, and so on.
Miss Afra, we have only 1 minute.
Causes the weight gain failure. Example for that, Cushing syndrome is very important part of the long-term health of all weight loss bariatric surgery. So the patient who undergoing bariatric surgery required intensive nutrition intervention as well routine nutrition evaluation, as well to be considered all bariatric surgery procedure creates some new risk for deficiency that is over and above pre-operative deficiencies. Another critical element is the patient themselves who must be committed to lifestyle changes, and it is happen when give the patient individual intervention. As well, the dietitian should be support for the patient to be able manage his nutrition requirement. Thank you for your listening.
Thank you, Ms. Afra, for wonderful presentation. Now we will go to the next our speaker, Dr. Habiba. Dr. Habiba Ali is an associate professor and the vice dean, Health Science Division, College of the Medicine and the Health Science, United Arab Emirates University. She is a registered dietitian with the College of Dietitians of the Ontario, Canada, and the certified diabetes educator by the Canadian Diabetes Educator Certification Board. Among her, the numerous awards are the Sheikh Mohammed bin Rashid Award for Medical Science and the United Arab Emirates University Faculty Researcher Publication Excellence Award. Dr. Habiba has a special experts in the area of the nutrition education and diabetes education and has conducted numerous workshops on the nutrition counseling for the health professionals. She also an associate editor for the MBC Public Health. Today, she will talk about decoding of the eating behavior, application of the ABC in the patient counseling. Please help me welcome Dr. Habiba.
First of all, thank you very much, Mahsouma, and I would like to thank the organizers of the conference as well as the participants of this session.
Dr.
I
Habiba,
have access to share because you know it's stable.
your voice a little bit.
You can hear?
Yes, yes.
Trying to, okay, share option, okay. Okay, good afternoon, good morning, good evening, wherever you are. So my presentation, as Masuma mentioned, is about decoding eating behaviors, applications of ABCs in patient counseling. In my agenda, I have 3 questions for us. Okay, the first 2 questions I will be able to discuss and answer. And the third question, it's for the audience to be able to answer. So my first question is, what are the ABCs of eating behavior? My second question is, how can we apply the ABC framework to facilitate client eating behaviors? And the third question, which I said is for the audience and for you to take it home and work on it, is how would you apply the ABC framework to modify your own eating behaviors? So let's look at first the learning objectives of my session. I have 2 learning objectives, which I will expect the participants will be able to achieve by the time we finish this session. The first one is be able to analyze the eating behaviors according to ABC framework. The second one is apply the ABC framework to facilitate changes in clients' nutrition behaviors. But let's start first with a brief introduction. We're talking about changing behaviors. So first of all, we need to understand that it's not easy for people to change behaviors, whether of lifestyle. And people will not change their behaviors just because we tell them. So we need to come to that realization. That's very important. So how can we do it then? We need to apply or utilize a number of behavior change theories and models and their strategies to facilitate clients' eating behaviors. That's how we can be more successful. So it's easy for clients to take it easy, relax, less active, eat unhealthy food. But what we want them to do is that to unlearn those unhealthy behaviors and adopt healthier behaviors. So instead of sitting, go for a walk. Instead of eating, talk to your friend. Those could be good recommendations. So the clients need to use both internal and external strategies to adopt healthy lifestyle. So now let's talk about the questions. The first question is, what are the ABC of eating behaviors? So here you can see A, B, and C. And you see the B is in the middle. And B is what is the behavior of eating itself, okay? So what comes before the B is A, which is the antecedent or the stimuli or the trigger for the eating. And what comes after the B is the C, which is how the person feels after they eat, which is the consequence. So changing eating behaviors, we said it's complex and it's very challenging. Why? Because there are many factors that influence our eating behaviors. This could be social, cultural, psychological, like you feel lonely or depressed or tired, or it could be physiological, like being hungry, or it could be other environmental factors that you see food around and you want to eat it. So all those conditions plus anything that can come before you eat or come after we eat can influence what we eat. In other words, it can influence the A and the C. So let's talk about a little bit more about the A's. What are these A, which is the antecedent or cues to eating in the environment? An example is seeing or smelling food, watching television, it can trigger for you to eat certain food, attending a social event, and that can also lead you to choose certain food or associate that event with certain food. Let's talk a little bit now about the B, which is the behavior of eating. what is it? It's about the speed we eat, okay? Who else is with us when we eat? Where are we when we eat? And are we engaged in other activities while we are eating? So what can be done with that is we try to adjust this. And we'll talk later about how we can do that. And finally, what is C? And C is the consequence. C is what people feel, the reward after eating, okay? Food is a pleasure, we know. Eating is a pleasure. Therefore, food may be considered as a reward by some people, okay? So what do we need to do then with the patient or the client in that case? Because food is a reward. We need to assist the clients in identifying other positive rewards which are not food. Okay, they need to find something else with each pleasurable. Okay, and we need to assist them with that. Okay, and as professionals, we can reward them by just saying, "Oh, you are doing great. You lost the weight, or you are eating healthy food. You are exercising more." So this will motivate them, and it will be like another reward or C. Okay, let's go now to analyze a bit more about the antecedents. Okay, we define what's A, what's B, what's C. Let's try to analyze the antecedents. So it can be the antecedent or the trigger or the cue to eating can be internal, psychological, such as loneliness. Okay, on all of these, we are going to help with the client. We need to try to adjust this. All right. So instead of this, we need to come up with an alternative for the client. It can be boredom. That's also internal. So the client has only something unhealthy around them. They are bored and they will just go for that. First, they may think about, should I do it, not do it? Then they give permission to themselves and they say, okay, I'm an adult. I can do this. It's my decision. And then they may go for the unhealthy food. Or someone else tells them, oh, this tastes good, even though it's unhealthy. And someone else, the external factor can motivate the person to choose unhealthy food. So all of those can be triggers for unhealthy food choices. And of course, it can be healthier food choices, depending on what's the food. Now, the trigger can be, for example, a person is engaged in an activity and then they associate that activity with a certain food or eating, okay? So for example, a person studying or watching TV can associate that with eating certain snacks, for example. Now, here you can see the whole story of ABC, okay? So you can take a second or a couple of seconds and look at this story of what happened to this man who was tired from work. Then he thought he deserves to have a big sugary drink. He goes and then he feels satisfied. And so that will be his C. So you can see now the sequence of events from A, B, and C. So now we talked about the first one. What is the first question? What are the ABC? The second question is, how can we apply the ABC framework to facilitate clients' eating behaviors? What we need to do is to modify, number one, the antecedents, the A. We need to modify also or adjust the B. And finally, we need to find another alternative consequences or rewards, which to modify the C. How can we do that? We can do that by applying the behavior change theories, behavior change techniques, and strategies. They can help us. Okay. So if we look at the A, you will find we can, for example, assist the client to identify the trigger. So first of all, the clients need to know what makes them eat certain food, because when people eat food, sometimes they are not fully conscious. They may be subconscious. Okay, so they need to understand, why they are eating certain food. Are they hungry, upset, whatever? So you need to help the client to identify the cues. Number one, those cues can be both internal or external, as listed here. Okay, And then we need to assist the client or the patient to identify new desirable cues, okay? Such as having healthy food around, okay? Or something that will help them, for example, exercise or something. So we then try to help them to remove those negative cues, but we cannot just remove something without the replacement. Therefore, we need to introduce or help them introduce new, healthier, positive cues around, okay, in the environment. The client may be able to restrict certain unhealthy behaviors to a certain time, to a certain place. For example, eat only at the dinner table, don't eat everywhere in the kitchen or in the living room. So those are certain strategies they can apply. We help the clients also to have cognitive restructuring, which is basically means reframing their thoughts. So from I cannot lose weight or I cannot eat that food, we need to assist them how they can say, yes, I can. Yes, I can do it. So in other words, we're giving them positive thoughts. We are teaching them how to see the cup half full, not half empty. Okay, in terms of adjusting the behavior itself of the bee, we can ask them to avoid other activities while eating, control snacks, leave some food in the plate, or just take small portions from the beginning and put on your plate, eat slowly, do not rush. For the C, we can ask the clients what else they can see as a reward besides food, okay? So this would be through discussion. Who would they like to be with? What other activities they enjoy besides eating? So through discussion, we will be able to identify what are the rewards, what the client feels as a reward. And finally, we can help the clients to modify the consequences. For example, instead of focusing, rewarding themselves with food, they can reward themselves with buying a pair of new shoes for walking, go to a movie. This man says, now I lost the weight, therefore I deserve to watch my favorite ball game or football, okay? So he is deserving, rewarding himself for something which is not food. As healthcare providers and support system of the client, friends, families, and so on, we can give a positive reinforcement, support the new healthier behaviors by giving praise, by telling them you are doing great, you lost the weight, your food is much better, now you are exercising more, you know, all of this. This will help them to stay on track. So my final question is, as I said, is the one for the audience. So which is, how would you apply the ABC framework to modify your own eating behavior? Okay? Because once you understand how to apply the framework to yourself, you will be, or we will be in a better position to help our clients, our patients. So how will you be able to do this activity? Okay, so apply the ABC framework to modify your own eating behavior. What do you need to do? Number one, first of all, identify unhealthy eating behavior that you, healthcare provider, would like to change, okay? Because that's how you will be discussing with the client, all right? And then you try to analyze this and say, what are the cues to this eating inappropriate food item? And how can these cues be modified? Can I fix it? Shall I remove it from here and replace it with something else? And so on. And if I do that, yeah, if I continue, for example, unhealthy eating or unhealthy lifestyle, you know, what were the rewards I was getting before? I was feeling satisfied, even when I eat unhealthy food, for example. So what you need to do now is to find a replacement. So identify positive new rewards, okay? So instead of focusing on food, which is or unhealthy lifestyle, you now identify new, healthier, positive rewards. These are the references which I have used. And I'd like to thank the audience for your participation. Thank you very much.
Thank you, Dr. Habiba, for lovely talk. Really, it was interesting to know it about the decoding of eating behavior. Now we will go to, okay. We will go to the third, our speaker today, Dr. Nader. Dr. Nader is a qualified medical doctor and chest specialist who graduated from Alexandria Medical School in 1990. Dr. Nader decided to change his career. This is very interesting, Dr. Nader. And moved into the field of the pharmaceutical sales, led him to be the MEA regional training manager with the Johnson & Johnson company. Dr. Nader has the extensive hands-on experience on the people management, development, effective team, people motivation, in addition to customer service. He is member of American Talent Development, certified master life coach, certified advanced public speaker, American Union of Neuro-Linguistic, Dr. Nader Al-Badawi, chairman Up and Aero Consultancy, professional learning partner, senior training consult. Dr. Nader, please help me welcome. Please help me to welcome Dr. Nader as he speaks to us about the patient centricity, how to engage our patient or your patient. Welcome to you, Dr. Nader.
Thank you very much, Dr. Masouma. It's always a pleasure to be here. So Professor Aisha Dahri, Dr. Masouma Al-Jasmi, my fellow speakers, and all the respectful participants here. So actually, I'd like to start by saying that for the whole of my life, I wanted to be a medical doctor. That was for me like a dream. And I remember when I was in the high school, I used to go to a nearby charity clinic and help the nursing staff with the patients, like changing the wounds, assisting with whatever I can do. Needless to say that I was trained by my auntie, who was the head nurse there. And I really saw myself as being a medical doctor. So yes, I graduated. I worked for 8 years. I took my specialty in chest medicine. And then all of a sudden I said, you know what, this is not for me, for so many reasons related to my style and my personality. However, I'd like to say that my clinic was very successful. I wasn't the most knowledgeable doctor in the area. I have a lot of professors who even were my professor in the university, but my clinic was as successful as their clinics because of a single little thing that I realized. I realized that patients coming to the doctor's clinic, they're not coming for a medication. They're not coming for a prescription. Honestly speaking, they are coming to talk. They want someone to listen. And honestly speaking, I did that. I was very successful, but I sacrificed my personal time. I used to start my clinic like 3 p.m. and finish like 2 a.m. in the early morning, sometimes 3 o'clock, sometimes 4 o'clock. And oh my God, 3 times in my life, I got troubles in the vocal cords because I was speaking too much to my patients. They loved me, I loved them, but I couldn't take it. So why I'm here today, I want to represent the voice of the patients before my all respectable audience and just open some doors, new angle of looking at the healthcare paradigm. So where are the good news? The good news is that, of course, everyone in this virtual event, you are successful. And if I might say that your success recipe actually is because of two main things. First of all, you, and when I say you, it's the package. Your experience, your education, your medical background, your characters, your attributes, the way you communicate with the patients, how passionate are you about being a medical doctor, which is very different from one to other. Do you see it as a job? Do you see it as a mission in life? So this is the first ingredient in your success recipe. Now, the second ingredient is your facility. You might be working in a state-of-the-art hospital where you have all the technological advancements, standard operating procedures, you have expert operating team beside you. However, there is another factor that many of the healthcare professionals, they did not pay attention to that. Your patients. Your patients play an important role in your success. And I just have 3 questions for everyone here in this fantastic event. So my first thing, if we talk about the patients, do we see what they see? Do we hear what they hear? Do we feel what they feel? How many times a patient came to you and all of a sudden he told you something like, you know, doctor, you really don't understand what I want to say. Doctor, you really don't feel the way I feel. Sometimes we miss that. So our patients are very, very, very important role. They have important role in our success recipe. And that's what I want to talk about today in the coming few minutes. Now, patients have been changed throughout the years. Consider that. Now, throughout the last 2 days, we have been talking about a lot of awareness campaigns, a lot of things that we need to teach the patients. No matter what we'll be doing, no matter how successful the awareness campaign will be, you are not giving them the full knowledge. They will not be as knowledgeable as you. So what's happened? You open doors for them. So when they go to the medical clinic, they will have a lot of questions for their doctors. And do the doctors have the time, the patient, to answer all these questions because of this awareness? Now, that's one of the change. The second thing, they want to be involved in the decision making. And I'd like to mention something that was very interested, that was mentioned here by Dr. Arfa. It's the bariatric surgery. What if I only see the bariatric surgery as the most successful, but the patient is scared, he doesn't want to do bariatric because he doesn't understand what is that. So they want to be part of the decision in many times. The third and most important change from my humble perspective is that we have so many generations. We have the baby boomers, those are in their 60s. We have the generation X, we have the generation Y, we have the millennials who are in the 40s, and every generation has his own characteristics. So we need to adjust our approaches according to the different generations we have. That's one of the challenge. Not only that, so many patients, they can question the knowledge you are communicating to them by just clicking on their iPhone or mobile to check if this knowledge is really what I really want to know. Shall I double check? And many times I see people, patients, who fall into victims of some websites that are not accurate, and they challenge many things. So this is some of the recent or modern year challenges we face in the medical community. Now, my question to you, and my first question that I want to raise, what are some of the patient's expectations? And I'd just like you to reflect for a few seconds. What really your patients want? What is that? And I don't know if you can have, you can put some ideas in the chat box if you want to do that. But what do the patients want? Think about it. Patients coming to your clinic, stepping inside. I would say, there is a very nice saying we say in human relations that people don't care how much you know until they know how much you care. In my humble opinion, this is the first thing patients want. They want to feel that they are admired, they are respected, they are here, they are listened, and that you really have this empathy to them. For them, that's very, very easy. Knowledge will come next. In my humble opinion, so many people will disagree with that, but I'm going back to the basics of the human needs. And my question here to you, what are the factors, what are the things you consider to show the patients that you care, to put them at ease and engage them in the conversation? And one more thing I want to highlight here is that not all the patients are the same. And I'd like to talk a little bit about the patient profile. We all know, and this is not new information, that in personality style, we differentiate or we classify people into 4 different groups, depending on 2 dimensions or 2 grid. That's the grid which is very famous and well known as the human behavior styles or social styles. So according to responsiveness, if the people are open to communication or introvert, that's the HR-LOR. According to the assertiveness, to what extent they feel comfortable talking about how they feel, what frustrates them, what do they think, do they express themselves clearly, confidently. Then we have 4 styles. We have the amiable style, we have the expressive style, we have the analytical style, we have the driver style. And why is that important? Because this is not only the patient style, this is your style as well as doctors. This is my style as well as human being. So let's have the quick look at this. The amiable person, that's a very friendly person. He wants to know how many kids do you have? Are you married or not? From which part of the Emirates are you? Where did you travel? What do you do in your weekend? Do you prefer playing football or playing tennis? What's your favorite movie? Do you like McDonald's or you prefer Hardee's or McD's? Those are the amiable people. They need to blend, they need to connect. Now, expressive people, those are very, very general picture oriented. Details will kill them. So if you tell me much details, you will see boredom in my eyes. They want to know the great pictures. And those people are very positive, optimistic, and they want to know what's coming next. They are futuristic people. Now, the driver people, those are the no-nonsense people. They don't have time, they are not patient, they are very poor listener, and they want the bottom. Don't tell me how the drug will work, tell me it will cure me. That's all what I care about. Don't tell me why I'm going to eat this kind of food. I want to know what to eat and when this will help me. That's it. Now, analytical people are the most challenging because they have a lot of questions. They are really into details. They want to know why you are saying this and not that. How do you base your decision? What are the factors? What are the criteria? What are the measures? How will I know that your drug is working? What kind of side effect I'm expecting and when? What will I do then? Now, the challenge is those opposites are conflicting. So the amiable person, he wants to chit chat, he wants to connect, he wants to blend. The driver has no time for that. Imagine if you are a driver doctor and your patient is amiable. What will happen? A big shock to your patients. Imagine if you are expressive and the patient is analytical, he has zillions of questions. What will happen? This is what I call the conflicting styles. So it's very important as a practicing clinician to adjust and modify your style so your message will get across the different kind of patients. And this is not easy to apply because the styles are very, very confusing sometimes. So in my humble opinion, there is 3 areas of conflict between you as a physician and your patients. I call that the tricentric approach. Let's have a look here. The first thing, achievement empathy. So you are the clinician, you are looking into achievement. Your achievement is to reach the correct diagnosis, to prescribe the right medication, to have the best results for your patient, whether it's cure or improvement. What will you consider achievement? Now, for this is not the priority of the patient now. The patient's coming to your clinic because he is sick. He has a lot of emotional baggage and he comes to you with lots of emotions. He might be frustrated, disappointed, angry, scared, in a panic. How do you deal with a patient that was diagnosed for the first time with a diabetes or with hypertension, something that's totally new? Not only that, let's talk about complicated scenario. One of the challenges I faced as a practitioner, as a chest specialist, how do you going to tell a patient with an advanced, lung cancer that he will die within few months? How can you tell your patient that? So this is some of the emotional challenges we need to deal with. This is why I strongly believe that no matter what specialty you are in, as long as you are a healthcare professional, part of your job is becoming a psychologist. So that's what the patient need. Okay, the patient doesn't want you to look at his liver. He wants you to look at him as a human being. Even in the pediatric, he doesn't want you to look at his stomach or the fat accumulating on his body. He needs to see the emotion, the depression each time he looks in the mirror. Now, the second paradigm is the doing being. Doing is what you do to me because you are the doctor and I am the patient. So you do to me the medical practice. Being is when you treat me as a customer. This is why when I run the patient centricity workshop to healthcare professionals, I ask them one question in the beginning. Do you talk about your patient as a patient? You said a patient came to my clinic, or you say a customer came to my clinic? And honestly speaking, patients now are becoming customers because they have so many choices, right? If I'm not happy in your clinic, immediately I will shift to a second clinic, maybe a third one. So we are in a competitive environment where patients need this being. They want to be welcomed as customers. And sometimes I honestly ask the medical doctors, did you enroll yourself in a product on customer focus or customer service or customer happiness? And honestly speaking, many of the doctors say, why do I need that? Patients coming to me because they have knowledge. I say, yes, but they have other choices. Have you thought about that? So it's up to you to think about that. Are you going to say that patients are coming to my clinic, which is good, but better to say customers are coming to my clinic? And we have seen so many hospitals growing because of these customer service approaches and because the doctors, they have outstanding communication skills. A point to think about. Now, the third one is really interesting. Is it autocracy or democracy? Means autocracy, I am the physician, I am the expert, I dictate to the patient what they need to do because that's for their best interest. Democracy is when, I discuss with my patient the different choices, the different opportunities, what they should do, what they shouldn't do. And I honestly speaking refer to what mentioned by Miss Habiba, right, about my previous speaker. And she said, you know what? People don't change their nutrition behavior. Dr. Habiba, people don't change any behavior, not only the nutritional behavior. It's very hard for us to change. And my question, not only to my fellow speaker, Dr. Habiba, to all the practitioners, do you really have the time? Do you really have the effort? Do you really have the stamina to change the behavior of your patients? Needless to say that in the private market, you might be seeing 30 patients in your clinic. So how you will find the energy to be this democratic and discuss with the patient so many options? This is one of the challenges we face. And I remember a few years back, I did a kind of patient centricity workshop to one of the elite hospitals. And the first thing the doctors told me, they said, you know, what's the challenge? I said, yes, I know. It's time. They said, yes, the hospital is pushing me because I need to spend on maximum 15 minutes of my patients. And with some patients, I need 30 minutes, maybe 45 minutes. So this is one of the challenges. And just a final thought I'd like to leave this fantastic group with. It's a kind of, assessing the way I handle my patients against the tricentric approaches. So do I really adapt to evolving patient expectations? Right? The patients came to me, I prescribed the medication, the patient came in the follow-up with this, and there was no improvement. So he has different set of expectations. Do I adjust to that? Or the patient's coming to my clinic and he thinks that, when he takes the first pill or the first injection, he will feel good. And these expectations change over time and feelings change. And my second question, do I vary my approach according to the types of patients? Do I really spend some time chatting with the amiable? Do I talk about the prognosis for the expressive? Do I talk into the details of the decision with the analytical? Do I just cut the discussion, go direct to the bottom line with the driver? Do I do that? And my third point, do I vary my approach according to the generations of the patients, 20s, 30s, 40s, 60s, teenagers? And my fourth point, do I apply tactics to establish good relations with my patients? And you cannot imagine the amount of research work talking about the doctor-patient relationship and how it relates to improvement the therapeutic outcomes, which is very, very well known. And my final point, do I involve my patients in the decision-making process so I increase the buy-in? And that's very interesting. We always talk about, patient compliance and patient adherence. And my question, how do you influence, and more importantly, how do you motivate and inspire your patients to follow the protocol you are mentioning or the regimen you are doing? How you will motivate the patients to apply the ABC tactics? And honestly speaking, after listening to Ms. Habiba, you know what was my plan tonight? I was planning for a big pizza. Today is Thursday. There is Pizza Hut Thursday offer, and that goes fantastic with watching a movie with warm family environment. Now I need to think twice about that. And finally, our patients really deserve to have the highest standard of human touch. And I'd like to end with one of the best quotes by Maya Angelou. She said, "They may forget what you said, they may forget what you did, but they will never, ever forget how you made them feel." Our patients deserve really to feel better. And with that, I say thank you very, very much. And it was really honored to be here in this session.
Thank you, Dr. Nader. Very interesting, very informative presentation. And we have to skip questions. We have a lot of the questions, but as we have important session, by a company of Abbott, Mrs. Mary, she will talk about the importance of the muscles and the protein across the continuum of care. Let's introduce Ms. Mary. She's the senior specialist for the Europe, Russian, Israel, South Africa, and Middle East, working at the Nutrition Science Team, R&D Department of the Abbott Nutrition, which is based on the Granada, Spain. She is a biologist and earned a doctor's degree in molecular and the cellular biology. She has the more than 15 years of the experience in the research and has been working for the Abbott for 8 years, where she has different scientific roles. During her professional career, she has been involved in different research projects related to carbohydrate metabolism, maternal health, healthy aging, muscles health, and diabetes. She has lectured about the different topics, mainly related to diabetes. Welcome to you, Ms. Mary.
Thank you very much for the nice introduction. Can you hear me well? Okay, perfect. So hello everyone, good evening. So my name is Maria Camprubi, and today I'm going to talk about the importance of protein and HMB to support muscle health across the continuum of care. So today we'll be discussing how muscle responds to aging and or stress. We'll discuss also the role and the relevance of dietary protein intake, especially in aging. And also I will show you some important clinical evidence supporting improvement in clinical, nutritional, and functional outcomes with nutritional intervention, including supplements with beta-hydroxybeta-methylbutyrate HMB. And then I will finalize by providing you with some take-home messages. So let's start about how muscle actually responds to aging and or stress. So here you can see in this slide actually what the muscle protein breakdown looks in the muscle. So muscle is constantly turning over, breaking down, and building back up. So you can see that muscle is a very flexible and dynamic organ, which is constantly breaking down and growing. Actually, there is an estimation between 1–2% of turnover of protein into the muscle. So you can see that there is a bidirectional communication between muscle and the blood flow, which actually communicates with the organs in the body. So there is a communication between amino acids in the blood flow that goes to the muscle to increase muscle synthesis, but also there is a muscle breakdown that release amino acids into the blood flow to support the energy and function of other organs in the body. So during a normal state, during healthy states, muscle protein breakdown and muscle protein synthesis are balanced. So there is a net balance between synthesis and breakdown, and then overall muscle is not lost. However, aging, inflammation, injuries, and illness, like hypercatabolic conditions such as cancer, can cause metabolic stress into the muscle. During metabolic stress, actually the body turns to muscle for energy, so turns these proteins and amino acids for energy, causing muscle protein breakdown. Amino acids are released from muscle and used by other parts in the body as a substrate in creating energy for functionality of these organs. So what really happens is like there is a loss of muscle mass, strength, and function. So that's why it's so important to keep this turnover, protein turnover into the muscle. So the muscle or the body has availability of amino acids and proteins just to support body homeostasis. So this is what it happens during a stress. There is increased muscle protein breakdown and a decrease in muscle protein synthesis, which actually leads to muscle loss. So let's see what's the role and importance of dietary protein intake to support muscle health. So proteins and amino acids have many physiological roles in the body. While some proteins and amino acids can be synthesized endogenously, also exogenous protein and amino acids are necessary to maintain homeostasis in the body. So skeletal muscle contains a large portion of endogenous proteins. Therefore, imbalance into the protein synthesis and breakdown may result in clinical conditions, including skeletal muscle atrophy, impaired muscle growth or regrowth, or even functional decline. During aging, these changes in protein metabolism actually have multiple functional alterations into the skeletal muscle that are accelerated by decreased dietary protein intake, and also inactivity and chronically elevated inflammation of the skeletal muscle can initiate and increase the pathological remodeling of the tissue. So that's why it's so important to define an adequate amount of dietary protein that's appropriate to maintain the ability, the availability, of amino acids for biological needs. So there have been many publications, many studies that have been completed to support the relationship between protein intake and negative outcomes. For example, here I would like to show you the Health ABC study by Houston in 2008. And they found actually that dietary protein intake was associated with changes in appendicular limb mass. So in the quintiles that only consume 10.9% of energy coming from protein, which correspond to an average of 0.8 grams protein per kilo per day, this has been associated with a significant more loss of appendicular limb mass than those that are in the fifth quintile that got 18.6% energy from protein, which correspond to 1.2 grams protein per kilo per day. So participants in the highest quintile of protein intake lost approximately 40% less limb mass than those in the lowest quintile, as you can see here. So aging and frailty are associated with a high risk of limb mass loss, which leads to physical disability and can be effectively alleviated by protein supplementation and muscle strengthening exercise. This is a systematic review of meta-analysis that included 19 randomized controlled trials, and they actually found that protein supplementation plus exercise, muscle strengthening exercise, show a significant improvement in limb mass, including leg strength and also walking capability. So their main findings were associated with a significant increase into the contribution to the efficacy of this intervention, including protein supplementation plus exercise in terms of muscle strength and physical mobility, and especially in elderly patients with a high risk of sarcopenia and frailty. So this publication actually supports the role of protein supplementation that actually leads to improvements in limb mass. Nutritional intervention, including protein, oral nutritionals with beta-hydroxybeta-methylbutyrate HMB, have been shown to help older adults maintain muscle mass and strength. But what is beta-hydroxybeta-methylbutyrate or HMB? HMB is an active metabolite of leucine. It's naturally produced, but in very low levels in the body from protein intake. And it's estimated that about 0.5% to 5% of dietary leucine is really converted into HMB. HMB is not a new ingredient. It's a unique ingredient that has been extensively studied. It's well established with their clinical benefits in sport nutrition, and it has been in the last decade where there have been so many studies in disease states and older adults, including HMB supplementation and clinical benefits for over 20 years. The most referenced dose of calcium HMB as a dietary intake is 3 grams per day, which has shown no safety issues, which is equivalent to consuming normal foods such as 110 eggs, 6,000 avocados, or 6,000 servings of asparagus, which is really impractical to be consumed from the normal diet. So HMB is able to address metabolic dysfunction into the muscle, but how actually can HMB counteract muscle loss due to metabolic stress? As I showed you before, under metabolic stress like inflammation, aging, or even chronic disease, there is a shift in the protein turnover in the muscle that is related to an increased muscle protein breakdown in conditions such as inflammation, and there is a decrease in muscle protein synthesis. So HMB is able to counteract, to shift this balance, so we have a net balance, net protein balance into the muscle. Its main role is related to decreased catabolic pathways. So HMB is able to inhibit or decrease muscle protein breakdown and also increase anabolic pathways that are involved in increased protein synthesis in the muscle. We have a strong clinical evidence supporting the benefits of HMB supplementation in older adults across the continuum of care. We have data supporting hospitalized patients under liver transplantation, reduced muscle breakdown in frail bedridden, improved muscle strength in bed rest adults. But also we have some data supporting the effect of HMB under chronic conditions. HMB is able to reduce inflammation in COPD patients, improve pulmonary function in COPD as well. And during healthy aging, also HMB combined with and without exercise is able to improve strength and function, reduce abdominal adiposity, or even improve muscle quality. Recently, it has been published a systematic review and meta-analysis by Dr. Beer in UK that has included 15 randomized control trials using HMB alone or included in supplements. And this meta-analysis has shown that there is a strong evidence, current clinical evidence, supporting the effect of HMB alone or in supplements to increase muscle strength. So HMB and its impact on skeletal muscle mass and physical function in clinical practice has been demonstrated. So with my talk today, I would like also to give you a call to action. So in terms of nutrition, screening, and intervention for at-risk patients. Protein, amino acids, or even their metabolites, such as HMB intake, should be considered, and supplementation may be warranted for those not meeting recommended intakes, and especially in elderly patients or in patients with chronic diseases. So what can you do as a clinician from clinical practice perspective? Screening and intervention. You should screen older adults patients for nutritional risk. Then you need to recommend increased protein intake to ensure patients are able to maintain their muscle mass, their muscle strength and quality of life. And you should even consider supplementation with all nutritional supplements, including key ingredients such as protein, vitamins like vitamin D, or even key functional ingredients that are muscle-targeted ingredients such as HMB. In terms of summary, so I would like to provide you some take-home messages. I show you how protein and amino acids can play an essential role in skeletal muscle health. We have seen that adequate protein intake can help limit and treat age-related and metabolic stress-induced loss of muscle mass, strength, and functional abilities. And we know, because we have a strong evidence, that increasing protein and HMB intake, especially in those older adults or under chronic disease, have been shown in multiple studies to improve muscle strength. So in terms of key interventions to preserve and improve muscle health, we need to increase the intake of muscle-targeted nutrients or muscle-building nutrients like protein or HMB combined with exercise. So thank you so much for listening. And now I will be happy to answer any questions that you may have. Thank you.
Thank you so much, Ms. Maria, for that wonderful presentation. Attendees, if you have any questions, please feel free to visit the Abbott booth. They have a booth in our exhibition hall where you can chat with a representative of Abbott. Thank you so much, Ms. Maria. And if there's any, I can't see any questions at the moment, but if there's any questions, I hope you allow us to send it to you and you can answer some of them.
Absolutely. Yes, thank you very much.
Thank you so much for your time. Have a nice evening, Ms. Maria.
Thank you.
Thank you. Ms. Rasan, we can move to you. Ms. Rasan, you're still muted. You're still muted, Ms. Rasan.
Unmute.
Okay.
Now you can hear me.
Thank you.
Okay, so hello everyone again, and very, very lovely day today with the IGD, and another presentation is now going on. We're going to start with Dr. Samar Al-Faqir, and that will be the first presentation for the last session. Dr. Samar is currently the regional focal point for community-based initiatives and health of older population. Dr. Samar is a medical doctor qualified in public health from Liverpool University, reproductive, maternal, and child health from Cairo University, and health system research from Johns Hopkins University in the United States. She is as well, she has a working experience with the World Health Organization and the EMRO in healthy settings research, primary community healthcare, and WHO Country Office of Somalia in health system and maternal and child health. What a very interesting experience. I would take hours actually going through it. We are honored to have you with us today. She is in addition as well, she has participated, Dr. Al-Faqih, in implementing urban health equality assessment and response tool in Egypt, Morocco, Jordan, Sudan, and Tunisia. Has many publications in the field of research, healthy cities, planning effective communication strategies, communication, and many more. And today her presentation will be about intersectoral action for promoting health during the life course from pediatric to geriatric, which is a very important topic, especially with our IGD conference covering all ages. Dr. Samar, you have 20 minutes, of course, and we'd be happy to hear your presentation. The stage is yours.
Thank you very much, and thank you for the great introduction and for all the organizers of such a beneficial and interesting conference. I will share my screen right now. Can you see the screen? Okay. We will talk today, as Razan mentioned, about the multi-sectoral action for healthy aging from pediatrics and to the geriatrics during the whole life course. And we are talking about healthy aging to avoid any ageism. So the main objectives of the session are to elaborate on healthy aging, to discuss the multi-sectoral action for health promotion during the life course, and introduce the baseline report of the Decade for Healthy Aging that has been endorsed recently by the UN all over the world. Now, what is healthy aging? Healthy aging is related to having or providing an opportunity for every person in every country in the world to have an opportunity to live a long and healthy life by creating supportive environments, the environment that they can live and avoid any harmful or any condition that can hinder that. Why environment? When we will talk about the environment, we will not talk about the environment per se, but everything that can influence behavior, like exposure to health risks, the air pollution, violence, access to quality health care services, social services, and also any opportunity that can the aging brings or create needs for. So healthy aging is about creating the environment and providing opportunities to enable all the population at any age group to be and do what they value throughout their lives, not only when they reach above 60 years old, but through all their lives, because any unpleasant condition can affect the person when he or she reaches the 60 or more. So being free of disease is not only the only requirement for healthy aging. Many people in many countries in the world, they perceive healthy aging that they can reach the 60 or above while they are free of diseases. This is okay, but it is not enough. But they have to have more health conditions and more lifestyle conditions, more support from the communities and the families surrounding them. So healthy aging is defined by the WHO or the World Health Organization as the process is the process of developing and maintaining the functional ability that enables well-being in older age. So to meet their basic needs, to learn, to grow, and to take decisions regarding their own health, their own activity, their own lifestyle, be mobile, whether at the home settings or outside the house at the community level, to go to park, to go to green areas, build and maintain relationships, whether among their families, among the wider communities, among their peers, also contribute to society. We know that the older population, they have wealth of experience, whether work-wise experience or life experience, so they can contribute to the society, conveying their experience and interact between the community member and provide services whenever they can whether on voluntarily basis or whether formally, if they can provide more support to civil society or any other party. Also, they have to have functional ability and also the intrinsic capacity of the individual, which will create or is highly needed to interact between the community or between the older population themselves and the surrounding community. So when we talk about intrinsic capacity, we talk about the mental, the physical capacities that the person can have, and also includes their ability to walk, to think, to see, to hear, and remember. So the intrinsic capacity is influenced by many factors, not only the diseases, but also any lifestyle related issues, and the nutrition is among the important factors that can influence and affect that. The outside environment can include the home where they live, the community, and the broader society. And any factor can affect the environment, can affect them, including the attitudes, the relationship they have between the surroundings, and also the systems and the local level they live in, whether the social, the health, any other system, even the transportation, the availability of the green areas can affect them. So the intrinsic and extrinsic or the environment, they can develop the capacity of the individuals, and they can help them to live in a better way and a better lifestyle. That's why we encourage the multi-sectoral action or multi-sectorality between different sectors. So when we talk about the intrinsic capacity, we can find the mental aspect, the health aspect, the interaction between population. Also the extrinsic factors, it is related, as I mentioned, to transportation, the urban planning, the environmental factors, the pollution, the violence. That's why all of such factors, we call them determinants of health. They fall under different sectors, not only the responsibility falls under the Ministry of Health or the health sectors or any other organization working for health. That's why we talk about the multi-sectoral action, and this is any health promotion intervention, we will find the multi-sectorality is mandatory. If we can provide a simple example to see how health promotion can be achieved by multi-sectorality, we can see the photo now of the tree. Then any other root factor or determinant of factor, whether environment, social and health context, biological context, it can be as the root of the tree. Then if there is coordination, the water and the nutrients will be transferred from the roots to the tree, and we can have then any other kind of the fruits that is hanging now, like conduction of training, building partnership, advocacy, building health teams, having policies or planning for strategies, and also engagement of the community, conducting research to create more knowledge and create more evidence that can be used for planning, for monitoring, and for tracking progress. This is, we call it in health promotion, the tree for multi-sectorality, through addressing all the social determinants of health, whether biological, social, or health, or environmental. Through coordination, we can have many forms of multi-sectorality that will help and ensure sustainability of any other intervention that can create progress and achieve progress that we are planning for. And here I would like to quote from Dr. Tedros Adhanom, the Director General of the World Health Organization, when they launched the Decade for Healthy Aging, and the United Nations General Assembly declared 2021 till 23 the Decade of Healthy Aging. He mentioned that announcement of the UN Decade of Healthy Aging sends a clear signal that is only by working as one within the United Nations system and with governments, civil society, and the private sector that we will be able to not only add years to life, but also life to years. That's exactly what we are hoping for healthy aging, not only to increase the life expectancy of the individuals, but also to live their lives in dignity and in the way they would like to see themselves and interact between different levels. So they add years to life and also life to years. The Decade of Healthy Aging, during the launching, we launched also the baseline report for healthy for the Decade of Healthy Aging because it includes many evidence and many case studies that can help the government and different countries to plan for the Decade of Healthy Aging, which we call it the Decade. The Decade was adopted by the 73rd World Assembly, and also it calls for participation, engagement, and collaboration, as I mentioned, between all the sectors, between the private and the public sectors, the civil society, the communities, and the older population themselves. This is by multi-sectorality, we will achieve measurable improvements on older people's lives, and we can, by conducting research and creating evidence, we can track the progress over the next 10 years. And this is exactly the focus of the decade. It provides how or different modalities and the mechanisms about how to achieve progress and how to track the progress. The baseline includes different evidence from different countries all over the world and some countries from our region. So we can know it can be considered as the baseline and also as a guide to track the progress over the next 10 years. Now, when we talk about multi-sectorality or multi-sectoral action, by resembling like the tree and how the roots represent the determinants of health and the trunk is the coordination. And by the multi-sectoral action and the creating multi-sectoral platforms, we can optimize the functional ability for older people to achieve, which is a key for healthy aging, and also it will help the elderly or help the older persons worldwide to meet all of their basic needs, and we can address through that the socio-economic and the gender inequities that can contribute to many differences and many discrepancies within the same country or between countries. Also, all over the world, the government and the other stakeholders, they need to invest in creating evidence and conducting research to monitor the healthy aging across the life course. And a limited number of member states, they have the available information. And also, we emphasize that older population themselves, they must be engaged in all stages of the multi-sectoral action because they are the ones who can convey the basic needs for them, and also they can benefit from the multi-sectoral action and they can participate and have an active role in that. This is some references where you can read more about the topic. And also you can find here the baseline report of Decade for Healthy Aging, where you can find many case studies from different countries and different regions That can include how the multisexuality can be strengthened, and how the older population can have an active role, and also the modalities and mechanisms for collecting information and the evidence to track process, and also to be used to translate policy into action. Again, thank you for you. And here I would like to mention the vision for WHO 2023, health for all by all. Thank you. And over.
Thank you so much. Thank you so much, Dr. Samar. Very interesting presentation. And we all look forward for the 2023 Health for All as well. Now we move on to Dr. Luay Ahmed. Doctor, are you with us here? Can you unmute yourself, please?
Yes, how are you?
Yes. Hello, Doctor. Dr. Luay Ahmed is an associate professor of epidemiology at the Institute of Public Health, College of Medicine and Health Sciences, United Arab Emirates University. He has special interest in the epidemiology and prevention of chronic diseases and the field of study design, research methodology, and data analysis. He has contributed to various successful research projects, received many research grants, and published several scientific articles. His current research focuses on the epidemiology of diabetes, cancer, and the mother and child health. Dr. Ahmed is the PI for the Mutaba'a, Mother and Child Health Study. He is also a co-investigator in many other research projects. And I have attended some of your presentation, and it was really amazing, Doctor, and looking forward to hear you today talking about Mutaba'a as well, Mother and Child Health Study. A very interesting topic, especially now we're coming to Mother's Day, so we really need to take care of our mothers as well. The stage is all yours, Doctor, and the questions and answer for Dr. Samar will be at the end of the session, and same goes for the other presentations for tonight. Dr. Luay, please, we're happy to hear from you.
Thank you very much for the introduction. I would also like to thank Professor Aisha Zahri and the organizing committee for the invitation and the opportunity to introduce and present and shed light on the Mutaba'a study. In this presentation, I will be walking you through describing the aim, objective, and methodology of the study, describe some expected outcomes and potential significance of the study, give you a hint or just a brief description of the general characteristic of the study population who are recruited so far, and summarize some few results and findings. As it's clearly stated and documented and nicely emphasized in many of the talks in this conference, that early life exposures have a major influence on the health and development in childhood and adulthood. In response to this, many countries have established birth cohorts to provide data repository in research for research in this area. Some of the famous studies are the Scandinavians birth cohort and the British birth cohort. Similar studies and data bank are needed in the UAE. Here at the Institute of Public Health, College of Medicine and Health Science at UAE University, we decided to move on and pioneer similar study in the UAE, and thus came the Mutaba'a study. The study aims to secure epidemiological data on maternal and child health in order to be able to investigate the health and maternal outcomes for the mother and the maternal early life determinants of the infant, child, adolescent health. The broad objectives of the study can be grouped as first to identify and collect data relevant to exposure and outcomes of the mother and the child during pregnancy, delivery, postnatal period, and early life, to associate, of course, relevant exposures and outcomes, and to establish a prospective and updated biobank. Now to describe the study methodology. This is basically a population-based prospective cohort study taking place at 3 major hospitals in Al Ain City so far. The aim of the study is to recruit 10,000 mothers and baby bears. Recruitment started in October 2017, and we were successful in recruiting around a little bit over 9,400 participants or pregnant women so far. And we are lucky that the response rate is very high, even compared to studies in the Western countries. Our follow-up time is planned for until the child turns the age of 16, And our main data collection tools are self-administered questionnaires and extraction from the medical record. For the study participants, our main inclusion criteria is to be a pregnant woman from the Emirati population, 18 years of age at least, living in Al Ain, attending any of the participating hospitals for the antenatal care, and able to provide consent. Together with the newborn, she will be eligible to be included in the study. In addition, the study also allows for inclusion of women with multiple pregnancies and those who conceive multiple times during the study period, of course, as well as their offspring, as long as they are providing the consent. This diagram here illustrates the recruitment and data collection timing and sources. At the recruitment sites, our recruiters will invite women who satisfy the inclusion criteria. After consenting, the participant will answer a set of questionnaires at different time points during pregnancy and afterward, and data is also extracted from the medical record at different time points. All the data will be stored in the data bank, the study data bank, and we are developing a user-friendly interface to allow interested researchers and investigators to browse through the domains and variables of all the data being collected, so they can select what suits their interest, in variables that could answer the research questions. They can submit proposal with the request of these variables, and all the procedure will be described and available for interested researchers in the near future, inshallah. Now, to visualize the data collection process from a perspective, we see here that at recruitment, the pregnant woman will answer a short questionnaire. This usually takes 5 to 10 minutes max, include around 67 questions. Then at a later stage, at the second visit later on, the same woman will answer a longer questionnaire. Now, this will include at least over 200 questions and a food frequency questionnaire. So on, the data collection process will continue for the pregnant woman or for the mother afterwards, and the child until the child reaches the age of 16 years. Here are some examples of the data collected at different time points. And we see that we are trying to collect as many attributes and information as possible that are not routinely collected in the medical record using different sets of questionnaire. For instance, we are looking for different lifestyle, socio-demographic, dietary, behavioral data for both the mother and the child. This kind of rich and valuable data is expected to enable us to study unlimited aspects of the mother and child health. For example, one can look at interaction between the pregnant woman lifestyle in terms of socio-demographic or pregnancy-related characteristics and issues related to pregnancy and pregnancy development and progression and outcomes, for example, gestational weight gains or cesarean section, mode of delivery, post-delivery events for the mother and the child. Also, some medical conditions affecting the woman during pregnancy can be related to many factors during the pregnancy, at birth, or even afterwards with the child. All these interactions can be explored in all directions. We are looking forward that all these investigations will help the study to contribute to informing the scientific community of the factor affecting the maternal and child health, and also to provide a local evidence-based scientific information to be able to build on the effort of the physician and public health policymakers to develop and improve the health and social services offered to the mothers and children in the country. The study also provides both undergraduate and graduate students the opportunity to participate in the study and develop and improve their research skills, and we are already successful in doing that and including some students with us. And ultimately, of course, to establish this valuable and rich scientific database for all researchers interested in the field of maternal and child health. To give you some Just a basic idea about some of the general characteristics for the study population who were recruited until the mid of last month, mid of February. There were around a little bit over 9,000 women recruited, pregnant women recruited. Here is the age distribution, and the median, the mean age was around 31 years. To go quickly for some of these characteristics, for example, we see that around 20% of the women were primiparous, around 55% reported that they planned this pregnancy, 50% were related to their husbands, and around 2/3 of them were worried about the coming childbirth. Of course, the list is very long, but hopefully this will be demonstrated in the publications. One of the advantages of the cohort study design is that it allows you or gives the possibility to utilize the data continuously and from the beginning. So you don't need to wait and finish the full data collection or complete the study before you can publish. So far, we managed to produce a couple of articles covering the different topics to give you just highlights of some of these. For example, here looking at the timing of antenatal care initiation among 840 pregnant women who were recruited at their first ever visit to the doctor for this pregnancy. We found that 50% of them came late or initiated their antenatal care late. That means they came for the first time for a follow-up for this pregnancy after they were already 4 or more months gestation. And we see that this is fairly the same regardless of the age. When looking at factors related to this, we see that factors like high level of education, previous infertility treatment, previous miscarriage were associated with appropriate maternal care initiation, while on the other hand, being worried about childbirth was inversely related to appropriate antenatal care initiation. In another analysis, we looked at the medical record to identify those who have had a history of previous recurrent miscarriage. That means they had 2 or more consecutive losses. And we found that this was documented for around 13% of the pregnant women, which is relatively a high rate compared to other population. We looked at how such kind of history could affect the outcome of this current pregnancy. And we found that those women with history of recurrent miscarriage ended up having more C-section delivery, more preterm or very preterm delivery compared to those with no history of recurrent miscarriage. The multivariate regression model confirms this increased risk, and we see that for cesarean section, preterm delivery, and very preterm delivery, the odds were very high in those who have a history of recurrent miscarriage. In another study, based on the baseline questionnaire, where the pregnant women were asked if they have had any, gestational diabetes mellitus, GDM, in any previous pregnancy, 30% responded yes to this question. Of course, this percentage, 30% coming out of those who were not primary gravida. So they need to have a history of previous pregnancy. This figure here illustrates the age and gravidity proportions by history of GDM, previous GDM. When looking at the association between history of previous GDM and some activities and behaviors of the pregnant women just before or during this current pregnancy, we found that those who reported a history of previous GDM within 5 years before this current pregnancy were less likely to plan this pregnancy, were less likely to have appropriate inter-pregnancy interval, were not taking appropriate folate before or during this pregnancy, and were more likely to be worried about the coming childbirth. I will give you one last example here about the knowledge and preferences towards the mode of delivery. We found that among those who were who answered this question or set of questions, 78% were demonstrate or showed a lack of adequate knowledge about the mode of delivery. This lack of knowledge was not different when taken into consideration the trimester of recruitment. And young women aged between 18 to 24 and women who already had the previous C-section delivery were even more likely to be classified as lack of adequate knowledge. About the preference towards mode of delivery, cesarean section was preferred by approximately 10% of the pregnant women, particularly those older women who are employed, multiparous, or those who had their last delivery by C-section. Currently, we are working on different research projects. Some of these are already submitted, some are on the way, and these are just a few examples of these. Usually, we prefer to investigate, for example, the status of every single health issue by reporting the rates and proportion first, and then explore what factors are could be potential risk factors for this issue, and what could be the potential adverse outcome for the mother and the child. Hopefully, this will be published soon. To conclude, can say that the Mutaba study now is providing a practical evidence that large-scale population-based cohort study can successfully be conducted and implemented in the country. We are looking forward to meet our initial target sample size of 10,000 pregnant women within the coming few weeks, inshallah. And we were able to establish very successful and productive collaboration with local and international academic institutions, and we are working on establishing collaboration with health authorities around the country. We are also working on expanding the study to include representative hospitals from Abu Dhabi, and we are preparing for Mutaba DXB in Dubai, and hopefully will be soon covering, or in the near future, inshallah, covering the whole of the country. As mentioned, and I would like to reemphasize again that the main goal is to establish data repository related to maternal and child health so that all interested researchers and investigators can use this enriched data bank to investigate this area and provide more useful research for many years and decades to come, inshallah. Here is just an overview of the funding organs and the ethical approval. And here is a list of our co-investigators, collaborators, personnel, and PhD students working with this study. In the end, I would like to thank you all for listening. And once more, I would like to thank the organizing committee for giving me the chance and to be part of this successful and important event. Thank you. Thank you.
Thank you. Thank you, Dr. Luai. Very interesting research ongoing as well for a long time. We know how hard it is to keep the participant engaging in the questions and to keep them for till 16 years old. That's something we'll be looking forward to read about it as well. And the good thing that we have step-by-step as well, data that we can use as well. Stay with us, Dr. Luai, and we will have the Q&A at the end of the session today. And now we move on to Ms. Mona. She's with us here, Ms. Mona Al-Hawai. She currently serves as Assistant Director for Administrative and Financial Affairs and Head of Nutrition at Al-Qasimi Hospital for Women, Childbirth and Children in Sharjah under the Ministry of Health and Community Protection. She holds a Master of Science in Hospital Management from Hamdan bin Mahmoud Smart University and a Bachelor of Food Science and Nutrition from UAE University. She graduated of the UAE Government Leadership Program of the Council of Ministries Future Leaders category. Graduate as well of the Quarter Centuries Foundation Sharjah Leadership Training Program under the supervision of Sharjah's development. Founder and active member of the Friends of Kidney Patients Association of the Supreme Council for Family Affairs in Sharjah, winner of Sharjah Medical Region Award for Career Excellence at Al-Qasimi Hospital Award for Career Excellence Supervisory category. She has as well worked in training a large number of female students in medical departments different universities in the country. What a diversified experience, Ms. Muna, all also poor in nutrition and health and serving different categories as well. And today she's with us to present something about parents, caregivers' influence on children eating. Welcome on board, and we'll be looking forward to hear your presentation as well, Ms. Muna. Thank you.
Assalamu alaikum and good evening, everybody. Thank you for your introduction, and a special thanks for the IGD committee team. I will start to share my screen. Is it shared now?
Yes, we can see it. Can you put it on a...
It's shared already?
Yes,
I can see that it's shared.
Presentation view, perfect.
Yeah, you can see the presentation?
We can see it, yes, go ahead.
Okay. So we will talk today about the parents' caregiver influence on children's eating habits. I will go through my presentation on a different literature reviews focused on different years and periods, different goals and methods, different countries and regions, and also a different conclusions. At the end, we will end our presentation with some tips and recommendation to develop and improve the dietary habits of those children. So I can say that no one can deny that the influence of parents and caregiver is highly affected directly or indirectly on child's character and life, including the food preferences. Many studies showed that it's strongly affected their body health, their sleep habits, oral health, their skills and competencies, and also weight status and dietary habits. And this will be our focus in our presentation. So let's start of the literature reviews from the oldest to the latest. This is one of our literature reviews, one of the studies which is comparing the children's socialized behavior to parents and non-parental agents, and examine self-regulated compliance to mothers, and half of whom were also observed with fathers for 90 toddlers. The study provides a first step by assessing consistencies in children's socialized behavior toward parents and non-parental social agents. The result shows both mean level and rank order stability in toddlers' self-regulated compliance to parents and caregivers. It showed also that the child emotion regulation and adult warmth control in a discipline situation were related to self-regulated compliance to the mother, father, and caregiver. Compliance also to the parents correlated with parental sensitivity and philosophies, and compliance to the caregiver correlated with child cognition and social involvement when child care quality was controlled. Also, maternal sensitivity and one control discipline predicted compliance to the caregiver, but not vice versa. This means the children model the behaviors of those around them. And when children are young, parents and sometimes siblings are the main role models in their lives. Therefore, children are likely to adopt the same eating habits as their parents. Since parents have the biggest influence at this time in the child's life, it is important that they set good examples, especially that we know that the children, they can see their parents as their heroes. And since they love their heroes, they will try to do the same. Our second study about the benefits of authoritative feeding style, caregiver feeding style, and children's food consumption patterns. This research tested the associations between caregiver feeding style and children's food consumption patterns among African American and Hispanic caregivers and their preschool children. Caregivers feeding style questionnaire is used in this study, and all results remain significant after controlling for child's gender and BMI, caregivers' ethnicity, BMI, and level of education. Overall, the results provide evidence for the benefits of authoritative feeding and suggest that interventions to increase children's consumption of dairy, fruits, and vegetables should be targeted toward increasing caregivers' authoritative feeding behavior. Means in some cases, the parents can use their authority in improving their kids' feeding behavior or food habits, but not always, and we can later on see why. Our next study is done for 261 children, completed the questionnaire, and their parents or caregivers completed also the questionnaire of their child feeding practice. And it's talking about understanding choice using the theory of a planned behavior and the role of parental influence. The result of this study suggests that for both groups of children, attitudes, subjective norms, and behavioral beliefs are important and very important to determinants of healthy eating. The result of this study support the application of the theory of a planned behavior to the prediction of food choice related intention and behavior among children. The next study, talking about the caregiver burden and coping patterns of Chinese parents of a child with a mental illness. Here, I choose something different to see what is the difference between the normal child and the child with illness. The data were collected via interview using a structured questionnaire from 97 mainland Chinese parents who had a child with mental illness, and explored the differences between parents of child with mental illness regarding many things, as caregiver burden, coping patterns, and demographic characteristic, which was really very important, affect parental educational level, parental working status, educational level of the child, diagnosis of the child, and the family economic status, which play also a role in that. The finding of this study revealed the parents received significant caregiver burden while caring for their child with a mental illness, yet used limited coping patterns to maintain a functional family life. The findings also suggest that effective nursing interventions should be instituted to help parents of a child with mental illness cope with caregiver burden while maintaining a functional family life, while the healthy food habit might be added within the intervention. If we go through another study, which is talking about effect of parental weight status on the food packed in preschool children lunches, I can say that because the goal of this study was to determine the association between BMI of the parents and the number of serving of fruits, vegetables, and whole grains packed, the nutrient content of preschool children's lunches, and norms and expectation about fruit, vegetable, and whole grain intake. Eating behaviors evolve during the first years of life as biological and behavior process directed towards meeting requirements for health and growth, which describes actually the factors shaping the development of children's food preferences and eating behavior during the first year of life, which contribute to accelerated weight gain and overweight. The result of this study indicate that there are few differences in the serving of fruits, vegetables, and whole grains packed by healthy weight parents caregivers compared to overweight and obese parents caregivers in a high income, well-educated population, although neither group met the recommended number of serving of vegetables or whole grains. Thus, results indicate the need for behaviorally based health promotion programs for parents, regardless of their weight status, especially that parents powerfully shape the children's early experiences with food and eating. And as we said, they are looking them as heroes. In this study, this is a randomized controlled intervention study, and it done a short nutrition education on feeding and positioning skills was provided to caregivers. So the study found that strengthening nutrition education and services for caregivers of children with CP has great value in the care of children with special needs and may improve the health outcomes of children as well as reduce stress among parents caregivers. the other study done between the age group of 6 to 13 years, and it's using a structured questionnaire and weight and height measurement. Actually, this is focused on the childhood obesity among school children in Bangalore city. And it's shown that the prevalence of overweight was 13.2% and obesity was 17.1%. The birth weight and sport was strongly associated with the prevalence. And this is a very important point. The sports protect the child from the overweight and obesity, and the parents' perception about their child's BMI status was good in this study. Parents' attitude to have meal with their child and their estimation of child's physical activity was protective, and the attitude of controlling diet of the child was a risk factor for overweight and obesity. So the study concluded that the prevalence of overweight and obesity is increasing, and that's good. Higher birth weight, parental attitude of controlling child's diet are the potential risk factor. Also, involvement in sports, parental attitude of having food with child, and awareness about their physical activity are protective. So we should remember that dietary habits are shaped at the young age and maintained during later life with the tracking over time. Eating behavior established in childhood, and really there is a lot actually of, when I do the literature review, there is a lot of studies are talking about the same point, but I choose some of them. The study of children's behavior should thus be seen as a starting point for targeted and effective nutrition education program, while at the same time suggesting further research strategies to elucidate the interaction between the various factors influencing children's eating behaviors. Sorry to say that there were a lack of such studies under this topic in the Arabian countries region. So let's look to the coming figure. We can notice here that this is actually showing the factors influencing children's eating behaviors. And we can see that the base of the pyramid was the genetic predisposition. And then we can see it's coming the parents and family, then the community, demographic and socioeconomic status, then the food, it's related to energy density and flavor, color. Then the child himself related to his feeding style and some other points. So if we focus about the parents' tip to help children maintain a healthy eating habits, we can say to support controlling child's eating habits, parents must empower children to self-regulate their eating and allowing them to make decisions about what and how much to eat. Parents' role is to offer a variety of healthful food, oversee the planning and assembly of meals, and set the schedule for meals and snacks. The child's responsibility is to decide what, how much, and even wherever to eat in some cases under their parents' caregiver supervision. And that is also very important, but we can say also, as it's shown in one of the previous showed studies, that the parents, they can use their authority also to choose their kids' food. So, what about the environment of the child when he is eating? What we can say and what tips we can follow? Have regular meal and snack times, and this will create a healthy routine. Eat together as a family without TV. Distant to eat healthier foods like fruits, vegetables, and whole grains. So it's a chance also. Avoid pressuring the child to eat. This we talked about it also earlier. This may actually cause them to eat less. That's why not always the authority of the parents can be used. So children should be allowed to decide how much to eat based on how hungry they feel. Avoid using food and a reward or punishment. but not always, because we can use that for a healthy type of food. For example, a UK study found that exposing 4 to 6 years old to vegetables and giving them stickers for eating them was the most effective at increasing their intake of vegetables compared to exposure plus or with only verbal praise. Have healthy food at home. The foods available in our fridge, freezer, cupboards, and pantries are what our children will eat. And this is normal. Being a positive role model, since we are heroes in their eyes, has an impact on their food choices. We can also encourage healthy eating habits, to make their favorite dishes healthier and reducing calories generally rich temptation by following these steps. Provide plenty of vegetables, fruits, and whole grains products in front of them. Include low-fat or non-fat milk or dairy products. Choose lean meats, poultry, fish, lentils, and beans for protein. We should let them or teach them to do that. Serve reasonably sized portions. Limit sugars, sweetened beverages, and limit consumption of sugar and saturated fat. Also, we can teach them to limit consumption of salty snacks as well and encourage them to drink lots of water. We cannot forget the physical activities, but always we are telling to the parents, start by yourself and help children stay active. Because a part of balancing calories is to engage in appropriate amount of regular physical activities and avoid the sedentary lifestyle. We can let them to do walking, jumping, football, volleyball, swimming, whatever of the physical activities. At the end, we can say, remember that what you put in your child's dish does not affect his habits more than what you eat in front of him. Small changes every day can lead to a recipe for success, and just to start the change. Thank you very much for your listening.
Thank you, Ms. Mona. We all need to hear that. And we know how much kids imitate their parents and they follow their lead, whether it's with the good or bad, and it affects their future as well, definitely. And I hope we can see some more studies in the Arabic countries, because this is where it's really well needed, and it reflects our culture and the way we eat, the way we serve food, which is supposed to be a good food as a Mediterranean diet plan in general, but it's the way we deal with it makes it hard.
Agree.
Okay, great. Thank you, Ms. Mona. And there's lots of questions as well. I'll be more than happy to pass them to you at the end of the session. Inshallah. And now we move on to Dr. Amita Atli. Hello, doctor. How are you? You are still
muted. Yeah, I'm very much here.
Yeah, hello. Lovely always to see you in every conference and every presentation. Your presence is very, very important. And for those who doesn't know you, they will be very happy to hear you today. And I will give a very, I would say, small presentation to what you actually do compared to what you are actually. So Dr. Amita has a vast university teaching experience of more than 20 years in India and the United Arab Emirates. I'm sure most of your students are attending right now. Briefly, she worked as a regional technical head in an international wellness organization based in Dubai. Her research interests span from community nutrition, focusing on nutrition assessment and education, population studies, to clinical nutrition topics related to bariatric surgery, autism, and metabolic syndrome. All three important topics. She has published in international peer-reviewed journals and invited as speaker moderator in different scientific forums. She has been a member in several national task forces and committees on nutrition with Ministry of Health and Prevention UAE, and collaborated with the World Health Organization, UNICEF, and other local organizations. And today we're looking so much to hear your presentation about dietary inflammatory potential and health status in young adults. Dr. Amita, I will not take much
Razan. Thank you very much, Razan, for your kind introduction. I'm just trying to figure out a way to share my slide.
We can see your screen.
Can you see?
Yeah, we can see your screen. It's already shared, but we need to see it in the presentation view, which is the top button. Yes, voila. Okay, and now it's all yours.
Okay, so good evening, everybody, and thank you once again, Razan, for your kind introduction. So before I begin, I would like to thank and extend my appreciation and acknowledgement to the organizers for giving me this opportunity to share the scientific platform with you all. So in the next few minutes, I would be talking about the inflammatory potential of diet and its associations with health status in young adults, which would be basically a focus in context to UAE. And this inflammation and health has now become a hot topic, not only in research, as we can even see its reflection in IGD 2021, that we have recognized that diet can modulate some inflammatory aspects of our health. So here we go. It is indeed no surprise that the prevalence of chronic diseases is high among UAE adults. And following the global, can you just tell me if you can see my cursor or pointer? Otherwise, I would stop using it.
Yes, we can see it, doctor.
Okay. Thank you. So following the global trends, CVD remains as the highest cause of proportional mortality in UAE adults. And according to the country profiles of 2018, WHO reports obesity prevalence of 30% being higher than the global average in UAE adults. And International Diabetes Federation in 2017 pointed out and placed the country 15th worldwide with 17.3% of type 2 diabetic cases, having many more numbers which are still undiagnosed. Poor health is not limited only to physical chronic conditions, but also find their way into mental health issues. And some preliminary small pocket-sized researches that have been conducted on adults in the UAE says that mental health disorders are commonly hit amongst the UAE adults, including depression, stress, and anxiety. And the overall health problems are compounded by the lifestyle issues, predominance of physical inactivity, smoking, and unhealthy dietary habits such as high calorie intake, high intake of energy-dense drinks, added sugar foods, fatty foods, and fast food consumption. Chronic low-grade systemic inflammation has now been recognized as an important factor in the development of chronic diseases such as CVD, diabetes, cancer. And not only that, even it is finding its way in the mental health issues, neurodegenerative diseases, including depression, anxiety, and stress. Smoking and substance abuse trigger an immunological response to vascular injury associated with elevated levels of inflammatory markers such as C-reactive protein, fibrinogen, white blood cell count. And on the other hand, aerobic physical activity could be effective in reducing this long-term inflammation, especially in adults with chronic diseases associated with a state of elevated inflammation. Diet is a constant factor which exposes individuals with potential to influence chronic inflammation. Therefore, there is a growing evidence in modulating this inflammation to reduce the cardiometabolic risks and other mental health illnesses by altering the intakes of pro and anti-inflammatory food components of the usual diets. And in this context, a novel concept of dietary inflammatory potential or dietary inflammatory index, DII scores, was developed in 2009, which was later updated in 2014 by the developers, Professor James Herbert and his colleagues in University of South Carolina, United States, with the goal of providing a quantitative measure of the inflammatory potential of diet and a predictor of various chronic diseases or chronic health conditions. It is based on the principle that the diet and nutrition are uniquely involved in influencing the inflammatory pathways due to their ability of specific food parameters. DII scores are computed based on a method that compares the individual's reported intakes to a global comparative database, which is derived from 1,943 peer-reviewed preliminary research articles on the effect of diet and inflammation. And they took 6 inflammatory markers, including IL-1B, IL-4, IL-6, IL-10, TNF-alpha, and C-reactive protein. And 11 food consumption databases from different countries around the world were identified that allowed the individual intakes to be expressed across 45 food parameters, including macronutrients, vitamins, minerals, flavonoids, and foods, each of them exerting some pro or anti-inflammatory effects, thus allowing the use of DII scores across different cultures and dietary patterns. And as you can see, the DII score of the maximally pro-inflammatory composite global database was plus 7.98, while maximally anti-inflammatory score of diet was minus 8.87 with a median of 0.23, which means that as long as we are eating near around the median value, we are as if having a neutral kind of a diet, and the higher the score, the more is the pro-inflammation or pro-inflammatory effect. A plethora of evidence has augmented on the use of DII scores and its association with health. And in the past 4 years specifically, more than 200 articles and studies have been conducted, ranging from cell culture to human observation and human experimental researches, and using this concept of DII scores, and 12 meta-analysis reports have been, or articles have been generated out of it, thereby elucidating that there is a strong relationship between the inflammatory potential of diet using these DII scores and using them as an assessment tool for health, for assessing the health status and predicting the cardiometabolic health conditions risk using this DII score. And it is good because it's a non-invasive tool. And considering this, there was a study which we conducted because university students are otherwise considered to be a relatively healthy segment of the population. Thereby, they attract somehow little attention in research. However, contrary to this belief, erratic schedules, their academic burden, it all imposes unhealthy lifestyles and food choices, which are including high calorie, fatty and sugary foods, irregular and skipping meals, resulting in lower consumption of nutrient-dense foods such as fruits and vegetables, and poor dietary habits would then impose serious threats to increasing the risk of obesity and heart diseases that may rise by 2 to 4% every year if the young adult is obese. And WHO World Mental Health Surveys reported that the mental health issues are also common among university students, and worse situation is seen in females in comparison to the male counterparts, thereby indicating that females are suffering more, female university students, if I be more specific, suffering more in both physical as well as mental health issues in comparison to the male students. And ironically, there is limited literature on the nutritional status and health aspects of university students residing in dormitories, who are actually likely to be more adversely affected than their counterparts residing off campus with their families in a natural environment. Stressful situations that these females may face could include their relationship with other residents and staff, time management, adjustment in the dormitory environment, to name a few. So with this background, a cross-sectional pilot study was conducted in 2019 at UAU in collaboration with University of Sharjah and the developers of DII scores at University of South Carolina, America, with the aim to assess the associations of dietary inflammatory potential, lifestyle, physical, and mental health status among students residing in the UAU. The sample comprised of 324 female students residing in the 5 dormitories of the university, and UAU offers a food service catering system which provides all the main meals to the students on the 5 working days of the week. Because majority of our dormitory students go back to different emirates during the weekend, the catering is not available on those 2 days. However, there are international students who are still residing throughout the week. So for them, we are still offering the food in the catering unit or through the
Dr.
catering unit.
Amita, I'm sorry to interrupt you. You have 5 minutes more to go, please.
Okay. Where was I? So validated tools were administered, and that included physical status in terms of BMI, waist circumference, lifestyle in terms of smoking and physical activity, as well as mental health problems in terms of depression, anxiety, and stress. I need to talk about a bit on the dietary inflammatory index scores, which were calculated from the 2-day diet recalls, one weekday and one weekend day. And we took out of the 45 food parameters, we could include only 38 parameters because alcohol is culturally not consumed, and the bioactive substances like flavonoids and all, their food composition and database information is not exhaustive, so we had to exclude them. The raw DII scores were adjusted for 1000 kilocalorie or energy density in order to control the interpersonal variations in energy consumption. And based on that energy adjusted DII scores were calculated, you can see that we had a wide range of consumption in the foods based on their inflammatory diets, or both pre and pro, anti and pro inflammatory diets. And we also divided our students according to the quartiles of DII scores. They were almost evenly distributed across these DIIs. And socio-demographic profiles revealed, as expected, they were mostly nationals, they were singles, and they belonged majority to the non-health majors. In terms of their lifestyle as well as health status, we found that though 70% could manage to have normal desirable body weight, but other than that, 30% were still having deviations from healthy weight, both in terms of BMI as well as waist circumference. Physical inactivity was common in more than 70% of our subjects, and smoking was found in the current smokers were almost 12% in the current study. And depression, anxiety, and stress were also commonly seen between 1/3 to 1/4 of the students. Just for the sake of simplicity, I have compared between quartile 1, which is more towards anti-inflammatory, and quartile 4, which is inflammatory, that some associations were significantly found with their self-health reported for good, poor, excellent, medical condition, whether it was there or not, whether they were smoking or not, and mental health according to their DII scores. The consumption of food groups also showed that those students who were belonging to the anti-inflammatory diets were consuming more of plant foods in comparison to high protein coming from animal sources from pro-inflammatory diets. And this is the last one, where it was reported that when we consider the anti-inflammatory quartile 1 as excellent condition, they were having higher probability and higher risk of having poor or fair health. They were having more medical conditions. They were currently smoking, and anxiety was high. So in order to conclude, we could say that university students in our sample also were having physical and mental health problems, lifestyle issues. High DII scores were associated with certain lifestyle conditions, physical and mental health issues. And to conclude, DII scores can potentially serve as a non-invasive tool in early detection of low-grade inflammation, and may be plausible predictor for future risk of chronic mental and physical health condition in young adults, and specifically some directives for universities and institutional policies that we need to monitor the physical and mental health status of university dormitory students, develop some comprehensive systems which are targeted, and food-based strategies are developed based on DII scores, and maybe develop some novel approaches in nutrition psychology to tackle such issues which are emerging both in physical and mental health problems in young adults, specifically in dorm students, but in general, overall university students. These are my references, and thank you so much for your attention and patient listening.
Thank you so much, Dr. Amita, for the presentation, and I will pass the questions as well at the end. And please note that Dr. Samar had a prior engagement, so she had to leave the call. However, if you have any question for her regarding her presentation, please pass them, and we'll try to send it to her as well to get your inquiries answered. And now for the last but not least as well, Ms. Aida will be presenting with us today. And Ms. Aida is a graduate with bachelor degree in food technology and nutrition from Faculty of Food and Agriculture in UAE. She's working as a senior community nutritionist in Community Nutrition Department in Nutrition Education Unit in Al Tawam Hospital, Siha, Abu Dhabi for almost 15 years. She was conducting lectures for the community, for different age groups, implementing awareness programs, writing articles in scientific magazines and internet websites, writing and designing nutrition cards to educate the government staff in Al Ain and Abu Dhabi by email as well. We definitely need all kind of awareness in all different kinds of media. She got staff reward as well and recognition award certificate from Al Tawam Hospital Al Ain, member in the National Committee for Nutrition to reduce saturated fats and salt and distance from trans fat, and member in ESMA committee. Participation in the Biggest Loser program for the students in UAE University Al Ain. She gave lecture in IGD as well 2018, Energy Drink Symposium 2019, Nutrition and Autism program in 2019, and today we are honored to have her with us as well in 2021 in the IGD, and her presentation will very interesting and new topic, and it affects the life of many people as well, became as a habit, cinema, theater, snacks, which and extends its danger to the society. Miss Aida, we are here, the stage is all yours. We'd love to hear your presentation and you can start.
شكرا يا رزان على المقدمة الحلوة. محاضرتي إن شاء الله بتكون عن وجبات دور السينما وتمدد خطرها على المجتمع. من أهداف محاضرتي إن شاء الله بتكون التعرف على تاريخ أغذية السينما وما طرأ عليها من تغيير. ثانياً أضرار الإسراف في تناولها والحلول البديلة الصحية، والتعرف على نتائج الدراسات والأبحاث العالمية المعنية بتأثير هذه الأنواع من الأغذية على صحة الفرد. محاور المحاضرة إن شاء الله بتكون عن بدايات دور السينما عالمياً وكيف دخلت في سوق الإماراتي، وأنواع الأغذية المتوفرة في دور السينما وفوائدها الصحية وأضرارها على جسم الإنسان، والبدائل الصحية المتناولة أثناء حضور دور السينما عشان يتجنبون الأضرار اللي هي الناجمة من الأغذية اللي تتوفر في السينما. وببين لكم بعض الدراسات والبحوث حول أغذية السينما وتأثيرها على الفرد وتمدد خطر هذه الأنواع من الأغذية إلى البيوت. في بدايات دور السينما كانت عام 1891. كانت الأفلام قصيرة جدا وكانت لبضع دقائق، يتم عرضها في قاعات أو في مسارح اللي هو المعارض وقاعات الموسيقى في غرفة مظلمة بإعداد شاشات فيها إضاءة. متضمنة كانت الأخبار اللي هي المحلية ومشاهد الأراضي الأجنبية والكوميديا القصيرة والأحداث الهامة. ترافقت مع هذه الأفلام اللي هي طبعاً اللي كانت على مساحات محددة بشاشات كبيرة، مكبرات صوت كبيرة، مع طعام كبير تتوفر فيها المشروبات اللي هي الغازية الضخمة، مع عبوات الفشار والحلوى الكافية عشان يبقى الشخص في هذه الدور السينما فترة أطول. في أوائل القرن العشرين قدمت نايكولوديميا التي ظهرت في البلدان طبعاً الصغيرة في جميع أنحاء الولايات المتحدة الأمريكية. قامت تقدم أفلام صامتة، وقاموا يشترون لمشاهدين الطعام والشراب من المطاعم المجاورة عشان يروحون يحضرون هذا النوع من اللي هي الأفلام القصيرة. أما في العشرينات والثلاثينات من القرن الماضي تم استبدال نايكلودينس بدور سينما أكثر رقياً. هي كانت هذه دور السينما مستوحاة من الطراز الأوروبي ومن مداخل اللي هي طبعاً القصور. فكانت هذه الأنواع من المسارح اللي هي طبعاً ما تسمح بدخول الأكل، فاستقبلت العملاء الأكثر ثراءً ولم تكن متسامحة مع الوجبات الخفيفة الفوضوية والمزعجة في دخولهم للسينما. فكانوا شو يسوون؟ لكن حاملي التذاكر انتهكوا القواعد في إنهم يهربون حلويات بسيطة كلاسيكية مثل الجود بيرز والميلك بادز والرينسنس والبوب وايت. فهذه الأنواع كانت من الحلويات اللاصقة اللي هي الكلاسيكية. أما ما بعد الحرب في منتصف القرن الماضي توسعت خيارات رواد السينما، شملت هذه الحلويات اللي هي اللاصقة بالأسنان مثل المنس، وهي حلوى الام اند ام اس، وبعدين حققت نجاحا أوليا مع الجنود الأمريكيين في الحرب العالمية الثانية، وحلوى السكيترز التي تم استيرادها عام 1979. أما اليوم تتحرك دور السينما إلى ما هو أبعد من الفشار، وإلى ما هو أبعد من الحلويات والمشروبات الغازية اللي تبلغ سعتها نصف جالون، فأصبحت تقدم هذه الدور السينما النقانق، الناتشوز المغمورة مع الجبن أو الصلصة، وتقدم أيضاً الآيس كريم مع العناصر الأساسية في مسارح السلسلة منذ عقود. فتتبيع المسارح المستقلة الحلويات الطازجة والقهوة المتخصصة. وبعدنا بنتكلم عن دور السينما عالمياً، فعززت اللي هي الحرب العالمية الثانية الجمع بين الفشار ودور السينما، فكان دايماً الإنسان يعني أو الفرد يوم يروح دور السينما دايماً مع الفشار، فتم تقديمه كوجبة خفيفة عشان اللي هو طبعاً يتسلون فيها في دور السينما. ففي منتصف الثلاثينات من القرن الماضي بدأت صناعة السينما في الانهيار، ولكن تقديم الفشار نجا من هذا الموضوع. كيف؟ إن في سنة 1945 ارتبط الفشار بالأفلام بشكل لا ينفصم. أكثر من نصف الفشار المستهلكة في أمريكا كانت توكل في دور السينما، فخلاص يعني معروفة أن مرتبطة الفشار بدور السينما. فشهدت دور السينما انخفاض مبيعات الفشار. ليش؟ لأن صار عندهم قلة الحاجة إلى الذهاب إلى السينما، فأصحاب دور السينما صار في كساد كبير، إن محتاجين إلى النقود والوقوف على الأقدام، فقاموا بتركيب موزعات الحلوى اللي هي باينة في الصورة أو العربات على رواد الأعمال اللي كانوا يتجولون في السابق في الممرات. بدأ بناء المسرح وأصبح الفشار شائعاً في الولايات المتحدة، طبعاً مع صنع أول آلة اللي هي طبعاً تصنع الفشار كانت في عام 1885. إنزين شو صار عنا وبعدنا في اللي هي بدايات دور السينما مع التطور؟ فمن أسباب زيادة شعبية الفشار بالنسبة لرواد اللي هم السينما، أولاً قدرته على التنقل. فمثل ما شفنا إن عربات اللي هي تصنع الفشار قاموا يتنقلون فيها بين الشوارع والأماكن اللي يعرضون فيها اللي هي الأفلام. ثاني شيء قامت اللي هي طبعاً ترتبط الفشار مع السينما لأن رائحتها جذابة عند إنتاجها. فهو اللي سمح للبائعين اللي هي طبعاً كانت لهم فرصة أكثر على أنهم يبيعونها بجانب دور السينما. وثالث شيء كانت سهلة التخزين مع أنها رخيصة الثمن، ولا زالت الأكثر مبيعاً تليها المشروبات الغازية والمعجنات واللي هي رقائق النشوز. أما في عام 1848 طبعاً الفشار صار اللي هو طبعاً من الأشياء الوجبات الخفيفة المنتشرة. إنزين كيف بدأت السينما في دولة الإمارات؟ وهذا أجمل يعني قصة بقول لكم إياها اللي هي عن دور السينما ودخولها في دولة الإمارات. فالسينما في الأصل نتاج اللي هو جهود عالمية من القرن التاسع عشر، فأصبحت وسيلة للترفيه والتواصل الجماهيري عندنا في الدولة وفي دول الخليج بشكل عام. ففي وسط التسعينات الستينات وبداية السبعينات ظهرت دور السينما في أول إمارة اللي هي دبي، وتليها الشارجة وراس الخيمة وكلبة ومناطق أخرى متفرقة في الدولة. فتعددت عندهم وسائل العرض والأماكن المخصصة لعرض أفلام عربية مصرية ولبنانية، وأيضاً بدأت دخول اللي هي الأفلام الهندية في دور السينما. أصبحت الأفلام مدتها أكثر من ساعة، ويتخلل هذه الساعة أيضاً فواصل، فتمكن المسوقين من توفير الراحة حق المشاهدين، فقاموا يوفروا لهم بعض المشروبات والمأكولات عشان يتسلون فيها أثناء المشاهدة. فالأكل ليس لسد الجوع، بل لأن المغريات المتوفرة جذابة للجميع. فنفكر شو هي الخيارات اللي قامت يعني تنباع مع دور السينما واللي مرتبطة دايماً بدور السينما. أول شيء اللي هي على تاجهم الفشار، فكانت في منها بجميع النكهات، كانت في المالحة بالكراميل، بنكهة الباربيكيو، بنكهة الجبن، وأيضا بالزبدة. وعندنا يليها اللي هي المشروبات، فقاموا يبيعون القهوة والشاي والعصاير السكرية والمشروبات الغازية والملونة وذو النكهات الصناعية. وأيضا قاموا يوفرون الحلويات، منها المصاص الغني بالسكر، الحلويات ذات القوام المطاطي، وأيضا الناتشوز بصلصة الطماطم أو الجبنة الكريمية أو الفلفل الحار، وأيضا الشوكولات بجميع أنواعها الغنية بالمواد الحافظة والغنية طبعا اللي هي بمحتواها من الألوان الصناعية والنكهات والمكسرات وبودرة الحليب. وأيضا قامت تتطور دور السينما بصنع اللي هي السندويشات النقانق وقطع البيتزا والكرواسون بالشوكولات، وأيضا المعجنات مثل الكريب مع الشوكولات أو الأجبان القابلة للدهن. وأيضا قاموا يقدمون اللي هو الحمد لله الماي وياها الأشياء. بس نحن مع تعددنا لهذه الخيارات المتوفرة في دور السينما، هل هي خطر على الصحة أم هل هي صحية بالنسبة لرواد السينما؟ طبعا عندنا دور السينما يعني الفشار من الأشياء اللي هي مهمة من الناحية الاقتصادية لدور السينما الحديثة، لأنه صانع الربح الأساسي لهم. فتحقق دور السينما ربحه بنسبة 85% من مبيعات الامتياز، وتشكل هذه المبيعات ب 46% من إجمالي أرباح دور السينما بشكل عام. عند تناولنا للفشار في السينما أو سواء كان في البيت أو غيرها، اللي هي طبعاً كيف هذه الوجبات وصلت لأيادي الناس في البيوت. فعندنا لازم نفكر بأن تناولنا لهاي الكمية من الفشار فهي كمية مذهلة من الدهون المشبعة. ثاني شيء نسبة عالية من الملح، وأيضاً سعرات حرارية عالية. فالاختيارات تكون متوفرة إما بالكراميل مثل ما ذكرنا، أو بالجبن أو بالسكر أو بالزبدة اللي هي طبعاً أو بالملح. فعندنا وفقاً لوزارة الزراعة الأمريكية إن 3 أكواب من الفشار اللي تعادل 24 جرام طبعاً مفرقعة بدون إضافة زبدة أو ملح أو زيت، فتعطيكم 93 من السعرات الحرارية كالوريز، وأيضاً 1 اللي هو جرام من الدهون، 1.9 ملي جرام من الصوديوم، 18.6 جرام من الكربوهيدرات، و3.6 جرام من الألياف، و0.2 جرام من السكريات على حسب نوع السكر المضاف له اللي هو كراميل أو أنواع أخرى من المنكهات اللي تنضاف للفشار، وأيضاً 3 جرام من البروتين. فنشوف اللي هي تفاوت في طبعاً التحليل الغذائي للفشار. ليس فقط الفشار هي وجبة السينما، عند تناول وجبة الفشار بعد في وجبة ثانية اللي هي الناتشوز، نسميها ناتشوز السينمائية. فأصبح الناتشوز أو رقائق الذرة المقلية المخفوقة في صلصة الجبن اللزجة كابوس عنا إلى حد كبير. ليش؟ لأن غناه بالسعرات الحرارية، وأيضاً يحتوي على نسبة عالية من الكوليسترول والصوديوم اللي يأثر على محيط الخصر، وبالتالي تأثيره السيء على القلب وأمراض القلب والشرايين. فعندنا رقائق التورتيلا المحمصة من أهم المقرمشات المنتشرة عندنا حول العالم، فيعود أصلها إلى المطبخ المكسيكي. والإضافات المعتادة والدارجة في هذا النوع من الناتشوز تكون إما بالجبن أو اللي هي صلصة الطماطم. فعند تناولك لرقائق التورتيلا شو تحصل على كمية مذهلة من الدهون، وستكتسب سعرات حرارية أيضاً عالية. في الصورة عندكم اللي هو نوع من أنواع الناتشوز اللي قاموا يخلونها شوي صحية، يضيفوا لها بذور الشيا. بس هل طريقة صنعها صحية أم لا؟ مع إضافة بذور الشيا هل هي صحية أو لا؟ فعندنا مثال على اللي هو طبعاً رقائق الناتشوز مع الجبن. فبنلاحظ أن نسبة الدهون الكلية اللي موجودة فيها 28% لكل 100 جرام. فالسعرات الحرارية الموجودة في 100 جرام 343 سعرة حرارية. بالإضافة إلى كمية الصوديوم العالية اللي تصل إلى 313 ملي جرام في أكل طبعاً الناتشوز. فيا ريت الشخص يكتفي يعني بالناتشوز في اللي هو حضوره للسينما، ولكن إذا كانت المصيبة يعني تكون أو المشكلة أكثر إذا كانت مع الفشار ومع الوجبات المالحة الأخرى. التطور الحديث في الأطعمة السينمائية المقدمة، مطعم وسينما اندماج في واحد. كيف؟ فصار توديع الوجبات الخفيفة المتعارف عليها في السينما، وأصبح الانغماس في المأكولات الشهية المعدة من قبل المطعم. ليش؟ لأنه صار الوقت اللي يقضون الأفراد في السينما صار أكبر وصار على مدة أوسع. فعندنا قامت دور السينما تقدم اللي هو طبعاً على مقاعد السينما إما هذه الأنواع من الأغذية صحية وإما تكون غير صحية. فقامت تتنوع الأشياء اللي تقدم مثل سلطة الفواكه، مثل ساندويتش نقانق مع مشروب، تكون اللي هي وجبة متكاملة، سلاش فواكه مثلجة. عندنا قام يقدم لفائف الجبن، قامت تقدم ناتشوز جبن بالفلفل ومشروب، وأيضاً فشار مع مشروب، أو ساندويتش الفلافل، أو الدجاج، أو ناتشوز بالبراتة، أو فلافل بالصلصة. وأيضاً قامت دور السينما تقدم أيضاً كبة بالصلصة. هذه من المطاعم اللي صارت موجودة في دور السينما. اللي نتساءل دائماً نحن نقول أنا صحية وأريد أكون يعني أبتعد عن هذه الأنواع من الوجبات، ليش نبدأ ناكل بكثرة في دور السينما؟ لأن أول شيء المكان مظلم، ومن الصعب رؤية كمية الأكل اللي نتناولها. تتفقون معي؟ انزين. ثاني شيء الفيلم يشتت الانتباه، ونقع في نمط من المضغ الطائش المفرط في أثناء مشاهدتنا لهذه الأفلام، وكل الموجودين يأكلون. فبالتالي يعني نحن لازم يعني إن بشكل طبيعي بدافع العادة والتأثير المحيط إن نشوف كل الأشخاص يأكلون، فنبدأ نحن اللي هو التقليد العفوي. مدة المشاهدة طويلة وتحتاج وجبة إلى وجبتين مثل ما ذكرنا، وتلبية الطلبات بأريحية وأنت جالس على مقعدك، ويوصلك الأكل لين عندك باللي هو طبعاً طلبات السهلة. متى تصبح الوجبة السينمائية عنا ضارة؟ في عام 2012 بيّنت دراسة أجريت على مستهلكي المشروبات الغازية، وهي مشروبات متوفرة في السينما كبيرة الحجم، تحتوي ما بين 384 إلى 696 سعرة حرارية، و96 إلى 174 جرام من السكر. فتتخيلون اللي يعادل 22 إلى 44 ملعقة صغيرة من السكر، وهذا يؤدي إلى السمنة وأكثر من الذين لا يشربونها. وأيضاً وجدت الاختبارات التي أجراها مركز العلوم في عام 2009 أن الأرقام الغذائية أعلى من المعلن عنها بالنسبة لمعظم المنتجات اللي تم اختبارها، بما في ذلك الفشار اللي يحتوي على 1200 سعرة حرارية، والحجم العادي الحجم الكبير يحتوي على 1200 سعرة حرارية، والحجم العادي 60 جرام من الدهون أيضاً المشبعة، مع إضافة ملعقة كبيرة من الزبدة حوالي 130 سعرة حرارية مضافة له. رغم أن الفشار الأقل في السعرات الحرارية والدهون المشبعة، لكن يحتوي على أكبر قدر من الصوديوم اللي يعادل 1500 ملي جرام، أو ما يعادل يوم كامل بالنسبة لمعظم الناس. وعندنا توصي جمعية القلب الأمريكية أن الحد اللي هو في اليوم الواحد المفروض الفرد العادي ياخذها 1500 ملي جرام من الصوديوم، فقد يؤدي استهلاك الكثير من الصوديوم بشكل منتظم إلى زيادة خطر الإصابة باللي هو ارتفاع ضغط الدم وأمراض القلب. في دراسة أجرتها جامعة كورنيل في نيويورك أن أفلام الحركة تجعلنا ناكل أكثر، فتشير الأبحاث إلى أن أطباق الوجبات الخفيفة تشهد الكثير من الحركة عندما يشاهد مشاهدون التلفزيون أفلام الحركة. وهذا يعني ببساطة أن كل ما شاهد الناس فيلم حركة كانوا يأكلون ضعف عدد الوجبات الخفيفة. أثر تناول هذه الدهون على الصحة ليس لطيفاً مع محيط الخصر وليس أيضا لطيفا مع القلب. والدهون المتحولة تزيد من مستويات الكوليسترول منخفض الكثافة LDL الضار، وتخفض من مستويات الكوليسترول عالي الكثافة LDL الجيد. بيدك الاختيار، تناولها أو تركها، لأنها غنية بالصوديوم، غنية بالألياف الغذائية المفيدة، ولكن إنها غناها بالدهون المهدرجة. هل تحتوي على زيوت؟ نعم. هل تحتوي على سكريات؟ نعم. هل تحتوي على كربوهيدرات؟ نعم. فالصوديوم هو أحد عوامل الخطر الرئيسية لارتفاع ضغط الدم والسكتة الدماغية بشكل عام. وأرجع أقول بيدك الاختيار، تناولها أو تركها. عندنا وجبة خفيفة صحية لعدة أسباب. لمحتواها العالي بالألياف الغذائية يعطي شبع.
سوري أقطعك، بس بدنا نمشي أسرع لأنه عم يخلص الوقت.
أوكي. فعندنا هي مصدر جيد للبوليفينول، وهي مضادة للأكسدة، تم ربطها بتحسين الدورة الدموية وصحة الجهاز الهضمي، فضلاً عن احتمالية تقليل مخاطر الإصابة ببعض أنواع السرطان. آخر اللي هو طبعاً السلايدات عندي وآخر المحاضرة، حابة أقول لكم بعض النصايح للمحافظة على نظامك الغذائي صحياً. أول شيء، اختار الوجبات الخفيفة الصحية. عند زيادة تناولها لن تؤثر على نظامك الغذائي، وعند تناول الوجبات الغير صحية في الظلام لن تكون متمكناً أيضاً من معرفة الكمية المتناولة. تناول لوح بروتين إذا كنت تحب قطع الحلوى والشوكولات والمكسرات المقرمشة أو المقرمشات بشكل عام، فتخطي الوجبات الخفيفة بلوح بروتين بدلاً من ذلك. ويكون مذاق ألواح بروتين منخفضة السعرات الحرارية جيد مثل أي شيء ستجده في علبة الوجبات عندنا الخفيفة، وهي أفضل لجسمك. وأيضاً اختر منتجات المصل تحافظ على السعرات الحرارية. إذا كانت الحلويات السكرية هي الحلويات المفضلة لفمك، واختر الحلويات قليلة السعرات الحرارية، لن تفسد في نظامك الغذائي إذا كنت تناولها باعتدال، فاختر الأطعمة التي يجب عليك مضغها. وفي نهاية محاضرتي الجملة الأخيرة اللي أقول لكم إياها، اللي هي التخطيط العقلاني سيمكنك من إنهاء ميزانية السعرات الحرارية الزائدة في السينما. وشكرا لكم.
شكرا مس عايدة على البرزنتيشن. I tried to translate everything as much as possible in everything that I read. And now we're going to go to the panel discussion. We have a lot of questions. And because we don't have a lot of time, so I'm going to start to give a question for every presenter. So we have the first question for Dr. Luay. Is there any nutritional factors associated with having a disabled child or autistic child? Would be great if it was considered in the study.
Absolutely. There are several studies confirm the increased risk of having disability for the children or among the children, and autism, for example, with many nutritional factors. For example, one of not exactly nutritional factor, but the gestational weight gain is now being proven or on the way to be proven as one of the risk factors for autism. Hopefully, this will be covered in the study, but as we are now still moving on from the pregnancy part until entering the follow-up of the children, hopefully this will be covered, inshallah.
Okay, thank you so much, Doctor. And we have another question here for Ms. Muna. A lot of kids hate most of cooked foods and vegetables. Also, some of them love a certain kind of food and suddenly decide to stop loving it. So how do we act in such situation and change it?
Actually, the cooked food can be given in a different way, in a different dishes, in a different shapes, colors, and even textures. So the parents should play on that to try to give their kids the healthy foods. There is a lot of things can be used, a lot of tools can be used, and even recipes. A lot of websites also can help them to show that. So But I can say to the parents and advise them always, start by yourself. You should know what is the healthy food. Then you should, by taking many steps, then later on you can change your kids' food habits, especially that you are their models.
Yeah.
So always I'm telling them, start by yourself. One, for example, of the things which I faced during my presentations and lectures in the schools, always I love to ask the kids or the students, what is your food dislikes? And most of them, they are telling me a reason which is related to their parents. For example, my father, he don't like tomatoes. Always he's removing the tomatoes from the sandwich. And sometimes about the salad, and also cooked vegetables. So most of them, they are binding their choice because of their parents, fathers, mothers, or for example, eldest brother. Yes. So always start by yourself to change and improve and develop your kids' food habits.
Absolutely. And actually, if I may add as well, from my experience with kids, one thing most mothers do is they keep on repeating that my child does not like vegetable, my child does not eat this and that. And then it gets into their heads, and kids started also adapting these things without realizing if they are liking it or disliking it, because their taste buds change over time, but because their mother said that they dislike, so they make it easy and they just stop eating it forever. Thank you. Okay, great. And I'm going to go back to you, Dr. Amita, but we have here another question on the, because I'm going sequential. There is Layla as well asking about, she noticed that the new generation children prefer to eat white pasta, pizza, and chocolate despite of availability of other food choices. So I guess this question will go for you, Ms. Aida, as well. Can you remove the mute, please?
اللي هو أغذية الأطفال دائما يعني تكون، أو أغذية البيت دائما نعلمهم على الطبق الصحي الهيلثي بليت. فهني نخليهم لهم اختيارات أكثر. وثاني شيء قراءة البطاقة الغذائية، مثل ما عرفنا أنه من تاريخ 11 كان لتاريخ عندنا 11 الأسبوع الخليجي اللي هو التغذية، فكان عندنا الإعلان عن البطاقة الغذائية اللي هي نظام الإشارات. فهذه كانت فرصة لتعليم أفراد المجتمع كيفية قراءة البطاقة الغذائية ومعرفة مخاطر كميات السكر والدهون والأملاح في الأغذية.
Yeah, so basically I will translate a little bit. So we need to educate them how to read the food label, how to make the good choices, whether they are in the cinema or at home, to always be cautious of what they're eating and the quality of the food that they are eating. Okay, and Dr. Amita, I actually don't have any question for you here, but let me check it. I have one question for you. Let me get my paper. Okay, 1 second. Okay. So, yeah, Doctor, has there been any study, the studies that you mentioned as well was all during that period. Is there any studies recently that has been done during the 2020, any questionnaire regarding the students' life and how it was affected by the corona, especially knowing that some of them are living alone? So how did this, if there is any study related to that as well?
You mean, am I unmuted? Yeah. You mean using DII scores or in general? Because in general, there are many studies. In fact, our colleagues also, they have published 2 or 3 studies or maybe more on the physical and physical activity, lifestyle changes, their psychological, mental health during the COVID time.
Okay.
And they have found,
Great. All right.
And the impact of COVID, yes, on their.
Okay, excellent. Okay, and I guess that's it for today. We wrap it up with all the interesting presentations. I think it's nice now to take a picture. Hello, Dr. Layla.
Hi, I think I just want to say thank you, everybody. We were out, but just watching also everything with you. Thank you so much for being with us and for making this really conference a success. I can't see everybody now. I don't know. I told him I wanted to see all of you and take a photo with you, but I can see only Razan. I don't know why I cannot see all of you.
Maybe
Dr. Leila, we can see you.
Yeah, we
Thank
can
you,
see
Habibti Dr. Amit. I saw all of you separately, but I wanted really now to take the photo with you, but I'm talking on behalf of Dr. Aisha. She's with me, but someone just came now. She wanted to be together, and she's now talking to them. So I send really our regard and our thanks to all of you for being with us and for making this conference a success and for giving these informative talks to everybody. Thank you so much.
Dr. Leila, don't worry. I took a screenshot and I will pass it to you with everybody in the presentation.
Thank you so much, Habibti.
So with this, we wrap up today's presentations. Looking forward for tomorrow, much more interesting topic as well. And really amazing IGD conference as always. I like the new topics that we're having this year as well. And especially doing it virtually somehow has its positives as well.
I mean, we got excellent feedbacks, really, and we felt that we are not physically together, but there is a lot of interaction. And this I don't know, not because we are the organizers, but we received a lot of positive feedback from everybody. Yeah.
True.
Thank you. Thank you.
Have a lovely evening, everyone, and also all the participants.
Right, before we end, can I ask everyone to please look at your camera for the screenshot? In a count of 3, please smile. Okay, in 1, 2, 3, smile. Okay, thank you so much, everyone. Have a nice evening.
Bye-bye. Thank you so much for all the organization and the team behind that. Thank you.
Bye-bye.
Thank you, Dr. Leila.
Bye-bye. Thank you. Bye.